All righty then. I think we are good to go. Hello, my friends. It is Jill Osborne from the Interstitial Cystitis Network. It is Sunday, August 2nd of 2026. It is time for another live IC support group meeting. This is a meeting for men and women who have been diagnosed with interstitial cystitis or might be struggling with bladder pain, pelvic pain, prostatitis, pelvic floor dysfunction, Hunner's lesions, you name it, it is what it is. Now, I'm going to tell you right now, the internet has been very funky this morning, and I'm hoping it's all set up correctly. You just never know these days. Hello, my friend. So we are live streaming right now on YouTube and on Facebook. Now, I'm going to tell you right now, I'm a wee bit disheveled today because we have been dealing with fires the last couple of days. We had a substantial fire out on the coast of California that had a horrific smoke. We got one clear day, and then yesterday we have another big fire that is still going on right now that is up threatening a small town called Hopland, which is about 20 miles away from me. Here's the thing about these fires is you have to monitor them. So the fire that started yesterday is a fire that if the wind had increased would have literally gone straight for where I live. And they moved that fast. I mean, the last fire we had moved 8 miles in 45 minutes. And so these are a big deal. So anyway, I've been up a lot the last couple of days. So if I'm a little bit disjointed, that is exactly why, my friends. Now, I got 2 phone calls today, early this morning, from IC patients. And they both said that they were going to watch. And so if you're now watching, it was an absolute pleasure to talk with you this morning. I always say, I got a little angel sitting on my shoulder who just whispers in my ear, you need to answer this phone. Normally I wouldn't pick up the phone at 7 a.m. on a Sunday morning, but I don't know, I did. And it was a really good, important conversation. Now, one of the conversations, though, really stunned me because 3 months ago, a newly diagnosed patient was diagnosed with IC and given Elmeron. With no warnings about their eyes, no warning about the potential for retinal damage, no warning about the risk to the bowels. It's like, what the heck are these doctors doing? How many studies do we have to have that shows that a medication has the potential of making some patients blind? And it's happening, and the company has paid $43 million to patients who have damaged eyes so far. And now we have all this new emerging data with the bowel and polyposis, and like, oh my God. If you look at our national guidelines very specifically say the doctor is supposed to discuss with you the risks and benefits of therapy so that you can make an informed decision about whether you want to risk your eyesight. And that didn't happen. And I'm sorry, but that pisses me off. Because I will tell you, I have worked with many, many patients now whose eyes have been damaged by this medication. And it is not okay to just prescribe it to a patient and not do really what our guidelines say you're supposed to do. Because the foundation of our guidelines, the American Urology Association guidelines for IC, is informed consent. It's all about shared decision making, and it is up to the doctor to make sure that you understand what the medication is, what it's supposed to do, what are the pros, what are the cons, and that simply didn't happen. It didn't happen in the doctor's office, and didn't happen at the pharmacy. Now, I will tell you that with that patient, I said, now listen, You're not blameless because you got a drug and information sheet. And at the top of the information sheet is a big black box warning. You got to read these too. And she pulled it out and she went, you're right. And I'm like, okay. And then, of course, we went and we started looking at other options and really talked about other things. But I just need to pound this into you now that you can't give your power away. You have to be equally involved in the decision makings about your treatment. You never, ever, ever let anybody give you a treatment without telling you what it is and what it is supposed to do. Now, and bear with me, I'm doing a little rant. It is what it is. There are some patients that I've worked with, they go, I've done every treatment. And I'm like, all right, what'd you do? They're like, I don't know. I did bladder installations. I'm like, okay, which ones did you do? I don't know. Now, wait a second. That's not good enough. You got to have records. Come on. You got to make notes. Over on the IC network in our free download area, it's a medical kit. Download it. Fill out your meds. Fill out who prescribed it. Fill out why you stopped it. I mean, like, we're trying to give you everything we possibly can to help you not become a victim. We want you to feel confident and comfortable and informed and ready to engage in a really good discussion with your doctor about what your treatments are. And you cannot walk into the doctor's office and say, please, I don't care what you give me, just give me anything. You got to be willing to ask questions. Hello, Margie. It's so nice to see you. Hello, Anne. Anne says, what's good for external vaginal itching? Well, Anne, it's about what's causing. Hi, Robin. It's nice to see you on YouTube. Hello, Joanne. It's nice to see you on Facebook. So, Anne, as I say to almost everyone, it's not just about treating the itching. It's about and treating the IC symptoms is about what's causing it in the first place. Why is that skin tweaked? Why is that skin so irritated that it's itching? So the very first thing that we're going to look at is there any chance that you've got infection? And this is why most gynecologists and urgent care centers have quick and easy appointments where you can go in, literally a 10-minute appointment. They can do a swab, take a look at it under a microscope to see if you've got candida. That would be scenario number one. There might be some sort of infection. Scenario number two is maybe we're dealing with some estrogen atrophy. Is your skin vulnerable because you're older? Is it drier? That's certainly possible. Third thing we're going to look for is going to be, is there any chance that you're having a chemical sensitivity? So I was working with a patient on Friday. Oh gosh, who was it, on Thursday or Friday? She was having terrible, terrible vulvar burning, just really, really irritated vulva. And so we're kind of like going through the causes. And she was doing like everything that I was told years ago you never do when you have an irritated, sensitive vulva. She was using a conventional laundry detergent that was, I don't want to say the name because I don't want to get sued, but 4 letters. She was doing a fabric softener that left a smell in her underwear. What else she was doing? She was doing a couple of other things that were just like, oh my God, if I was doing that with my vulva, I would be crying every night. Hello, Julie. Julie, explain, honey, what's going on after Tuesday? Anne says she uses topical estrogen. All right. So, Anne, let's go back and let's make sure your vulva is not being tweaked by something. All right. Now, if we're trying to do protection, if your vulva needs some protection, so let's say you've got some urine burn, we would do vulva balm or coconut oil, something like that. If you've got lichen sclerosis, and your doctor would probably have given you a steroid cream like clobetasol. You might benefit from lidocaine, just a very simple lidocaine gel just to turn it off. That's possible too. Okay. All right. So now, you guys, for anybody who's new here, our meetings can go, our last meeting was 4.5 hours. We did it. All right. Sometimes our meetings are 2 hours. Sometimes they're longer. I am here as long as you have questions. All right. And so feel free to ask me any question you want. I double dog dare you to try to embarrass me. I am here for you. Hello, Brooke. Okay. Julie says after her DMSO treatment. You might not be here after Tuesday, after your DMSO treatment. I don't understand. Brooke said, thank you for talking to me about my hydrodistension, cystoscope, Botox in the pelvic floor, and pudendal neuralgia or pudendal nerve block. My bladder is flaring like crazy. Vulvar burning, rectal burning, pain is completely back after the pudendal nerve block wore off. Not sure what to do next. Well, Brooke, the fact that the nerve block turned the pain off tells us we're dealing with a nerve issue, right? And so we've got to do everything that we can to try to calm that nerve down. So you can call that doctor back and make sure you say, hey, man, the nerve block really worked. And now that it's worn off, I'm really uncomfortable. Number two, you could do something that will calm nerves on the skin. You can do some lidocaine there. You could do PEA to calm nerves down. All about calming nerves down. Julie says she's done this since 2002. She's mad. Honey, I hear you. And if I could just give you a big giant hug right now, I would. And I want you to remember that, like, we're sitting right next to you. We're not in front of you. We're right next to you because we have all been on this journey before. And girl, I'm telling you right now, this meeting is for you because here's the deal. If you're not responding to treatment, if you're getting worse rather than better, I wonder if the diagnosis was correct. Could they have missed something? And that's our topic for today. So normally when I do these meetings, I do a little 20 to 30 minute little educational thing, and then I take your questions. But we got a couple questions coming in, so let me just grab these questions really quick. And then I'm going to go into confusable conditions. Okay, so hold on. And Julie, please feel free to call me. If you want to call me after the meeting, if you want to call me tomorrow, I would love to talk with you. You're not in this alone, girl. You're not. Pamela says, doing a colon test tomorrow. I have blood in my colon, blood in my bladder for years. Colon test hurts with medicine, so we use. Good luck, honey. Good luck. Now, please know that if you were taking Elmeron is associated with inflammatory bowel disease. So make sure you tell your doctor that. I was working with a patient last week who had just had her bowel removed or a partial colectomy like 2 months ago. And she was stunned to learn that the medication that she'd been taking for a significant amount of time was the likely cause of all of her bowel issues. Kieran says, what does a pelvic ultrasound look for? Will it show the bladder and urethra? Vaguely. Well, the purpose of a pelvic ultrasound is really to look mostly for retained urine. Do you have urine retention? So normally when you go to the doctor, especially the first time, they'll have you urinate. And then they'll do an ultrasound immediately afterwards to see if you have fully emptied your bladder. And if you haven't, then we know we might be dealing with a voiding dysfunction, some urinary retention, something like that. Pelvic ultrasounds can identify other interesting structures, like an ovarian cyst, things like that. I don't think it is a good measure of the health and integrity of the bladder wall, but maybe it might show a little bit of bladder thickening, but I think a CAT scan would too. And an MRI is considered the most important diagnostic test for sure, because that allows the doctor to really look at the soft tissues. Okay, so Borea says her DMSO treatments are helping so much. Good. I'm glad they're helping you. Then that tells us that you're a bladder wall-centric patient. Miriam said, my doctor wanted to do a urodynamics test, and 2 days after a cystoscopy, I have bladder pressure. I'm so afraid of getting the urodynamics test. I told him but they still recommended it. I canceled it, and I'm just now doing the cystoscopy. Do you think that's reasonable? Well, what our guidelines say, multiple guidelines around the world actually say that urodynamics is not, it's optional. It is not a required diagnostic test for IC. It is really a test that will check for how the nerves in your bladder are functioning. And so it is considered optional, and it's usually done kind of after the cystoscopy is done, because our number one goal of diagnosis, if you have pain as your bladder fills with urine that is relieved by urination, is to ponder the health of the bladder wall first. And so a doctor might do an in-office cystoscopy to look at the bladder. The doctor might do an anesthetic challenge where they put lidocaine in your bladder. And if it turns all your pain off, then we can say, okay, your pain's coming from your bladder wall. If you have extreme frequency and urgency, but you don't have pain, that's when they might want to do the urodynamics a little bit more to just try to understand if the nerves in the bladder are being functional or not. And that urodynamic, listen, I had a urodynamic, nothing to be afraid of, really. Really, all they're going to do is insert a device in your urethra, and they will slowly fill your bladder with fluid. And they're going to ask you, okay, when do you first feel the need to urinate? And you're like, okay, now I feel it now. And then they're going to say, okay, tell us when you first feel you uncomfortable, you feel pain. And you're like, okay, I feel it now. And then they might push a little bit past that just to see how far they can go. And it tests what we call your awake bladder capacity. You know, one of the challenges that IC patients sometimes have is that we tend to have a very sensitive nervous system. And so, for example, you could take a normal person without IC or central sensitization, put 500 or 1,000 cc's of fluid in their bladder. Man, they can walk around for a couple of hours before they need to pee. Now, like in my case, I have a perfectly normal bladder. But if you put that amount of urine in my bladder, I will need to pee right away. You could put 200 cc's of fluid in my bladder, and I'm going to feel it, and I'm going to be looking for a bathroom, even though I have good bladder capacity. And that's because the nerves in my bladder are just more sensitive. So awake bladder capacity is just kind of a measure of, I don't know if the correct word is functional bladder capacity. I don't think that that's the right word. It's just how much can you hold comfortably? And then if you ever have a hydrodistension with cystoscopy, and why am I wearing my earbuds? No wonder I sound so muffled. When you have an anesthetized, when you're under anesthetic and they're doing a hydrodistension with cystoscopy, they're also going to fill your bladder, but they're measuring your anesthetized bladder capacity. And that is, what can your bladder really hold? They've turned your nerves off, you're asleep, you don't feel anything. How much physically can your bladder hold? Okay. And, you know, we now have kind of a more discussion about what's normal and what's not normal, that if you have a bladder capacity over 500, that's considered very good. If you have a bladder capacity under 500, they're suggesting that that might be a sign that we have a bladder wall that is compromised for some reason. I will tell you that my bladder, if I remember correctly, my bladder capacity has always been like around 450. And a lot of patients are told, well, you just have a small bladder. Well, no, it might be more that you just have more sensitive nerves. Julie, it is right at the top of the IC network. It's an 800 number. Just go to icnetwork.org and you can get that number. Hello, Bonnie. Nice to see you. And Frey just says here urodynamics wasn't bad. Yeah, I mean, like, really, the only challenge with the urodynamics is that your urethra gets tweaked. And the only other thing I would say with the urodynamics is, I mean, like, look your doctor in the eye when you're getting ready for it and you're laying there. You look him in the eye and say, "This is my safe word. When I say pizza, I expect you to stop. That means that I am very, very uncomfortable, and I don't want you to push much farther than that." I think just having really good, clear communication. You don't just lay there and take it. It is okay for you to say, "Ow, that hurts. You can stop now," which is exactly what I did when I had mine. And they kind of look at you, "Oh, you can take a little bit more." "No, it hurts. You can stop now." But it's all about clear communication. There are some macho doctors out there who tend to ignore us. And I think you just have to have a safe word and just say, "Listen, I've had enough. You can stop." But it wasn't that bad. It just wasn't that bad. I mean, would I do a urodynamics right now on camera? Yeah, I would. Would I do a cystoscopy on camera right now? Yeah, I would. Like, literally, neither one of them scare me. And they give me good, valuable information on what's going on. So I'm not worried about either one of them. Really, the only long-term ramification of either test, and it's not even long-term, it's short-term, is that your urethra is going to hurt like a bitch the first day. First couple of times you pee, your urethra is going to say, "Hey, man, you stretched me, and I'm going to make you pay for it." But that goes away. You can always ask for some pain medicine too. You don't need 30 pills of any pain medication. You could say, "Hey, doc, listen, I know this has a chance to be a little bit uncomfortable. I would really appreciate it if you could give me a couple of Norcos. Order just 3-4 Norcos and opiate medication so that if I am struggling, it will help me." Okay, you guys on YouTube here, is the sound okay? Robin, do me a favor and let me know if this sound is okay. I am feeling like there might be a problem on YouTube. I'm not sure. So YouTube is on this, and it is working. Facebook is on this microphone. So you let me know. Okay, Brooke says, "I ordered your PEA. I used compounded gabapentin lidocaine baclofen cream. It doesn't help much. I'm on low-dose gabapentin twice daily, but I have to stop due to swelling. Didn't help much either." All right. Frey says, "I'm having a hard time finding someone who does DMSO. They mostly do basic cocktails." The reason why, Frey, is because, I mean, DMSO has really fallen out of favor as a bladder installation because it can hurt. Most doctors prefer to do an anesthetic, or they prefer to do a rescue installation, heparin lidocaine, where when you have it done, you generally walk out of the office feeling much better. So DMSO is what I would consider kind of a very old school therapy. I mean, I had 8 DMSO treatments. Didn't do a dang thing for me because I am not a bladder-centric patient. I am a pelvic floor-centric patient. So DMSO became popular back in the 70s, 60s, and 70s when we all thought IC was an incurable bladder disease. Now we know that IC is a pelvic pain syndrome for which there are many potential causes. And so the role of DMSO has kind of fallen because now we know that the great majority of patients have muscle problems rather than a bladder wall problem. So DMSO is not going to help tight pelvic floor. All right, Julie. Julie says the liner in her bladder is worse, so maybe we're dealing with some more atrophy. Okay, honey, listen, we'll talk, girl. We're going to talk. Don't you worry. Karen says, "If my mom is elderly and gets frequent UTI, shouldn't it be reasonable to give a daily antibiotic to a 90-year-old? It would be common to give a 90-year-old a prophylactic antibiotic, but until we address the underlying problem, which is usually atrophy, we're still not going to we like to prevent the infection from the first place rather than just treat it all the time, because the more antibiotics you use, the more you disrupt the biome and potentially cause other conditions like C. diff. And so normally when an elderly person has recurring UTIs, it's because they have atrophy in their vagina. That's what the research shows. I attended a big class at the National Institutes of Health on this years ago, and they explained that 24 hours before the bacteria arrives in the bladder, it's usually living in the vagina quite happily. And this then led the researchers to ask, well, what's happened to the vaginal defenses? And the answer is, again, atrophy. So we want to make sure your mom, if she is able to use our estrogen cream, that would be very, very important to try to get her skin as healthy as possible. The second thing you could do is you could inquire about her immune system. Some patients have a damaged immune system, which is making them more vulnerable to infection. In fact, one of the patients that I was working with today was on an immune suppressant. And so she was struggling with a lot more recurring infections. And this is where you can do lactoferrin to boost your immune system to help your body fight off infection. Or you can make your urine fairly caustic and unfavorable to infection by doing something like prevent. Let me show that to you. Prevent. And you guys understand that this is a Sunday and I'm always very, very casual, okay? Because I work 6 days a week. So don't be disappointed if you see me in very casual clothes. I am not dressed up for these meetings at all. All right, so prevent. Prevent would be something, it's a D-mannose combined with a PAC product that many, many patients use to try to prevent infections. So you could do prevent and lactoferrin before you resort to the antibiotics. But if she has a super drug resistant infection, if she's prone to super drug resistant infection, her doctor may want her on legit antibiotics. So I would follow the doctor's guidance also big time. Big time, my friend. Pamela says you go pee 90 to 100 times a day. Okay, so that tells us the nerves in your bladder are fried. And we have to figure out why. Something has massively irritated the alpha afferent nerve in your bladder wall. So we have to figure that out. This nerve, the alpha afferent, is the nerve that controls frequency urgency. It is a nerve that is very easy to turn on, and it's fairly hard to turn off because it is a nerve that tells you when you need to urinate. So at some point in time, something is tweaking that nerve, and we've got to figure that out. It could be that you have a Hunner's lesion and urine is getting into the bladder wall where it's directly irritating the nerve. It could be that you've got that you're eating or drinking something which is very, very provocative and neurostimulatory, such as anything with caffeine. It could be that you're dealing with a lot of neuroinflammation from very, very tight muscles, but that is exactly why we use phenotyping. And yes, they can put antibiotics directly in the bladder. And we have 2 UTI vaccines that are getting very, very close that are going to change the face of UTIs for sure. I understand, Julie. I understand. We can even talk after the meeting, girl. If you want to hang tight, we can go into Zoom after the meeting if you want to hang tight, but we'll connect. You've got my number. Feel free. You can feel free to call me after the meeting. Miriam said, what about getting a UTI from the test? Well, normally when they do any sort of big invasive procedure, they usually give you an antibiotic to prevent that. Frey says, I can't do a cystoscopy awake. It's horrible. Jill, do get it done awake. I've had 2 done awake and 1 done asleep. It's not, you have to differentiate between a hydrodistension versus just a plain cystoscopy. Anytime they're stretching your bladder with fluid, yes, You want to be asleep for that, for sure. But if they're just sticking an instrument in there to take a quick look around, you might not need anesthesia. But it's entirely your choice. Denise says her doctor treats you with macrobed for 5 days before a cystoscopy since you're prone to UTI. Okay, Brooke is asking about pudendal neuralgia. We're going to talk about this. Okay, you guys. So let me just do what I have to do with this meeting first, and then we're going to come back to these questions. Understand that Facebook scrolls really quickly, and it's really easy for me to miss a question, and you have my permission to be a squeaky wheel. You can ask the question over and over until I answer it. I am not offended by that at all. That is my policy for people who are trying to get a hold of me by phone. Feel free to call several times if you need to. If you call me and I text you back, I can't talk right now, that just means I'm working with another patient. You have to be patient. First come, first serve on the phone every day. All right. Robin. Okay, now, whoa. Before I get into my thing, hold on one sec. Robin had another. Okay, hold on. I got to get a picture here. Hold on. So Robin on YouTube was our big mystery a month ago because a doctor did a cystoscopy and found black marks. And we have pictures of them. Okay, we've never seen this before, ever. I mean, like, you look at this one, man, that looks like a sliver coming out of her bladder wall. That is freaky. And the doctor at the time when they did this test did not do a biopsy and pull it out to look at it. So we sent it off, because we sent her pictures off to a bunch of the top IC doctors. Nobody really knew what it is. So she finally had another cystoscopy, and there weren't any. That's so weird. I bunkers. Those black marks are gone now. Just bunkers. So you had another cystoscopy by a different urologist. There were no black marks. He said he didn't know how to help me, but at least you got the answer. Okay, that's good. And you apparently have your ovary is adhered to your vaginal cuff. It may be breaking through. You have an appointment with a pelvic specialist in October. Good. And I understand it was scary. Thank you, Egric. Thank you. All right. So we got to talk, my friends. We got to talk, because IC has for many, many years been what we call a grab bag diagnosis. What that means is that we have a patient with frequency, urgency, pain, and we don't know why. And so there was a doctor who did an interview online. We were all really outraged when he called IC a grab bag diagnosis. We felt that we were being minimized, but he was absolutely correct. Interstitial cystitis is, in fact, where a lot of urologists dump patients because they don't really know what's going on, or they can't explain what's going on. They just can't. And so now we've got millions of patients struggling with IC who may have been misdiagnosed. And here's the deal, like Julie, listen, if you've done bladder therapies for years and you're not better, or you're getting worse over time, our national guidelines from the American Urology Association say, stop what you're doing, take a step back, revisit the diagnosis. We don't want you to keep doing therapies that aren't working. Instead, we want to understand why they're not working to try to find your correct diagnosis. So, for example, for me, I was diagnosed with I was diagnosed with a urethral stricture when I was 13. I was diagnosed with vulvodynia when I was in high school. Then I had irritable bowel, lots of other things, and then interstitial cystitis when I was 32. But here's the deal. Every bladder treatment I did didn't work. None of them worked. And that's hard when you're the patient because you're suffering. We were suffering. I suffered. I had a doctor say to me, you will always live with severe pain. And I'm like, no, I won't. I will prove you wrong. Which I did. I proved him wrong. And here's the deal. It turns out it was never my bladder. When you look at my bladder, I have a perfectly normal bladder. It was muscles so tight, they were like concrete. Why? Because when I was 13, I broke my dang tailbone. Why were my muscles tight and squeezing my urethra when I was 13? Because I broke my tailbone. But we didn't understand that back then. We didn't understand the importance of the muscles and how the muscles influence bladder symptoms. We didn't understand the importance of tailbone injuries. We didn't understand the importance of endometriosis. Today we do. Today I see it's a diagnosis of exclusion. It is your doctor's job to rule out a lot of other stuff before they say, hey, I think you've got interstitial cystitis. But the hard reality is that they can't do that in a 15-minute appointment. Or worse, you may have health insurance where they're not allowed to do that. Listen, our healthcare system is not ideal for somebody with a chronic pain disorder. It takes time. And most importantly, some doctors simply don't have the training to do this anyway. Pelvic pain is a very unique specialty because they've got to understand the urinary tract, they got to understand the reproductive tract, they got to understand the bowel, but more importantly, they got to understand the muscles and nerves. And it's very hard to find a doctor who's got training in all of that. That's why there are so few pelvic pain specialists. So a pelvic pain specialist is going to go through the list. And that's what we're going to do right now. I really want you to think about it for patients who are not responding to therapy. And, if you were to call me and we were doing a coaching session, first question I ask is, how old are you? Second question I ask is, how old were you when your symptoms began? I want to know, is it just been the last couple of years? Has it been 6 months? Or was it back when you were a kid? Because that already provides very, very valuable information. And then the most important question is there any event that you associate with the onset of your symptoms? Did anything happen that you think caused it? So, for example, a patient I was working with on Friday, her symptoms began after the birth of her last child, and she suffered a stage 4 muscle tear. So she was an injury patient. She didn't understand the role that muscles can play in driving bladder symptoms. And if I remember correctly, when she finally went and had her muscles checked, she too was like concrete, just like me. And understand, bladder therapies, bladder installations aren't going to do a damn thing for tight muscles. If you've got tight muscles, we got to work with those muscles directly. All right, so let's go through the common confusable diseases. And I know we did this a little bit last week, but we're going to do this again because it's really that important. And hopefully those of you who are on our mailing list, I sent out a newsletter yesterday morning that went to 36,000 patients. And this was a lead story. And in fact, we have a big article on our website that's going to share some of this information. So what are we going to look for before a diagnosis is made, an IC is made? Do we have bacterial cystitis? Of course, they should be doing a urine test, urine dipstick, urinalysis. And that's particularly important if you always feel better on antibiotics. If you always feel better on antibiotics, then it might even be reasonable to have a next generation DNA urine test to make sure you don't have an infection that a typical culture could miss. Okay. We're also going to look for a chronic fungal infection. Why? Because we've all been exposed to a lot of antibiotics. I mean, if there's ever a group of patients massively overexposed to antibiotics, it's us, because we all think we have infection. Many of our doctors assume we have infection. Many of our doctors put us on long-term antibiotics. I did very aggressive long-term antibiotics in my 30s. Ended up with a drug-resistant, wicked fungal infection. Yeast in my bladder. Yes, you can get yeast inside your bladder, and I am here to tell you it is agony. This is not normal bladder pain. Having a fungal infection in your bladder hurts like a bitch. So if you flare after eating sugar, you flare after eating carbs, that could be a sign you have a fungal infection, and they have to do a special fungal culture. And we got the research to back this up from the NIH IC research team, the MAP Research Network, which found that the more fungus present in your bladder, the greater the pain. So we want to make sure that's not happening. We want to rule out tuberculosis. Tuberculosis can infect the bladder. So if you've been traveling and you were in a country where there's rampant tuberculosis, we want to make sure that you didn't get it because it can move to the bladder. We want to rule out bladder cancer. Now, there's really no relationship with IC and cancer, except sometimes a patient might be misdiagnosed with IC when in fact they do have cancer. So if you were a smoker, you need to have a urine cytology test because the number one cause of bladder cancer is in fact smoking. The number one cause of bladder cancer is smoking. And we're going to throw vaping in there too. There's a lot of toxins in vapes too. And did you know that children that live in the home of a smoker exposed to secondhand smoke, they too will end up with bladder irritation? And we got the research to back that up too. And I grew up in the home of a smoker. My mom smoked when she was pregnant with me. And she was a smart woman. She just was of the generation where they were told it was safe. Okay, we want to make sure you don't have what I call a chemical injury to the bladder wall, what they call inflammatory cystitis. That means if you've gone through chemotherapy, the chemicals of the chemo damage their bladder. If you use ketamine, ketamine can damage the bladder. BCG, environmental toxins, anything at all like that. The bladder can be injured like any other part of the body, and it's going to be injured through chemical exposures. I was once working with a mother who had a daughter who had a really wicked case of urinary symptoms. And it turned out their well water was contaminated with pesticides, and that was the underlying cause for her daughter's difficulty. We want to rule out overactive bladder. Overactive bladder, again, these patients generally don't have pain. What they have is incontinence. So when they struggle with frequency urgency, they're running to the bathroom because they're worried that they're going to be incontinent. Whereas an IC patient is running to the bathroom because they're trying to reduce pain. Okay, we want to rule out something called bladder outlet obstruction. And this is where the bladder neck, or there may just be something obstructing the flow of urine. For a man, that might be benign prostate hyperplasia, but it can also be scar tissue from other surgeries, etc. And so if, for example, you urinate, but that sonogram finds that there's still a lot of urine in your bladder, that's a sign that we might be dealing with a bladder obstruction. If you have a history of brain injury, spine injury, or MS, any sort of neurological dysfunction, those have the potential of affecting the bladder as well. Somebody with neurogenic bladder, they often can't feel the need to urinate. In fact, I was working with a patient last week who literally could not feel when her bladder was full. She had no sensation of needing to void. That's a sign that we're dealing with something related to damaged, injured nerves. And if you ever cannot urinate and cannot have a bowel movement because you can't feel it, you feel numb down there, that is an emergency. And you get yourself to the ER. We call that cauda equina. And the goal here is to really understand why you're numb and fix it, because we don't want nerve damage, which would eliminate your ability to empty your bladder. Okay. The next thing we're going to look for is something called a bladder stone. Bladder stones are like kidney stones, but they form in the bladder. These are rough, chunky, sharp little mineral deposits. They can happen if your urine gets super concentrated, and sometimes they grow out of the bladder wall if your bladder wall has been damaged significantly. Like kidney stones, they tend to be covered with bacteria. Like kidney stones, they float in urine and they cut your bladder wall and introduce bacteria in your bladder wall. So one of the more memorable cases of a patient I worked with, she was afraid to have a cystoscopy. She had really significant symptoms for years. And after, I don't remember how many, 8 or 9 years, something like that, she finally let the doctor look in her bladder. And guess what? She had a giant bladder stone. And that was why her bladder was screaming at her. And once they broke it up and took it out, she was fine. Is there a chance you have a foreign body in your bladder, like mesh? You ever have a rectocele repair or a cystocele repair or a prolapse repair where they use mesh? Mesh can migrate into the bladder. Sutures can migrate into the bladder. And there can be something called a urethral diverticulum, a little pocket that comes off of the urethra, and sometimes they can come off of the bladder. It's like here's your bladder, here's a little tiny pocket next to your bladder that happens when you strain a lot. If you're straining hard to empty your bladder, or you're pushing hard to have a bowel movement, you have the potential of pushing against areas that are weak, and they can pop out and create these little pockets that can be quite painful. Here, hold on. Okay, so that's it for the urological confusable condition. So now let's go to the gynecological confusable conditions. We want to look first for sexually transmitted disease, chlamydia, gonorrhea. Now, I remember when I was 32 and this happened to me, I hadn't been in a sexual relationship for a couple of years because I was dealing with all these other symptoms. And frankly, I couldn't care about sex at that point in time. And the doctor was like, yeah, we're going to test you for STDs. And I'm like, why? Why? And they're like, we always do it. Don't worry about it. And that's true. They're always going to do it. We want to rule out STDs. Even if you're 90 years old, newly diagnosed, they're going to check you for STD. We want to check for vaginal infections like candida or ureaplasma, which can certainly trigger urinary symptoms. We want to check for pelvic congestion syndrome. If you feel a heavy weight in your pelvis that gets worse as the day goes on until by the end of the day, you feel like you're carrying a bowling ball around, that's a sign that you might have a varicose vein in your pelvis, pelvic congestion syndrome. That is blood pooling in your pelvis, very treatable and curable. Do you have atrophy, estrogen atrophy? Doesn't just affect your vulva and your vagina, it affects your bladder. We can treat that too. Do you have endometriosis? Endometriosis can attach to the bladder. It can attach to the urethra. It can burrow through the bladder wall inside the urethra. So, and if you have very, very painful periods, you have very bloody periods, might want to get screened, have a sonogram or another test to see if you have endometriosis. We certainly want to rule out any other cancers that might happen in the reproductive tract. The patient I was working with this morning is facing a hysterectomy because she's got complex endometrial hyperplasia with atypia, just like I did right before I had my hysterectomy about 8 years ago. We want to make sure you don't have pelvic inflammatory disease, which is treatable. And we want to make sure that you don't have vulvodynia or lichen sclerosis. You got to remember, nothing operates in isolation in the pelvis. Everything influences everything. And we have something called neural crosstalk. So if you irritate the nerves in the bowel, odds are those nerves are also going to get irritated in the bladder and vice versa. And the same is true with the vulva. I remember I said to my doctor, the wonderful Dr. Klein, who is now retired, who I adore, who diagnosed me with IC, I kept saying, okay, this is how my flares begin. I start with vulvar pain. Then I have for a day. Then I have urethral pain for a day. And then it hits my bladder and I have bladder pain. Can you explain that? And he said, no. I said, it happens every time. Okay, now we understand that that's probably just nerves slowly getting inflamed across the pelvis. Because again, I have a healthy bladder wall. There's nothing wrong with my bladder. I'm entirely neuromuscular in origin. Okay. So pain on the vulva can certainly, oh my God, listen, pain on the vulva is consuming, and you are going to feel like you're going to need to pee more, and you are going to feel like you have a bladder infection and a vulvar infection. It's very, very confusing because everything is throbbing down there. And all you know is you're running to the bathroom. So it must be your bladder, right? Well, sometimes it's not. Okay, what are the colorectal things that can mimic IC? Well, of course, you want to get checked for colon cancer if you're older, for sure. Well, not even if you're older, if you're younger too. If you got blood in your stool, man, you got to go to the doctor right away and get that checked out. Remember, speaking as a cancer patient, the earlier you catch cancer, the easier it is to treat. We want to check for, again, diverticulitis, any sort of inflammatory bowel disease. And we want to check for irritable bowel syndrome. So if you're going between, if you have diarrhea all the time, constipation all the time, or you're rotating between the two, that's a very clear sign that we're dealing with irritable bowel syndrome. Now, the most common cause of IC symptoms that many doctors miss is the fact that bladder symptoms can be driven by the pelvic floor, by musculoskeletal causes. So specifically, if you have pain in the abdomen, the low back, the perineum associated with bladder, bowel, or sexual dysfunction, you flare when you have sex, you flare when you're in the car driving, that tells us we're probably dealing with a muscle issue. We want to look for hernia. Is there any shot you have hernia? So I was working with a patient last week who had pain on the left side, either the left or the right side of her groin, not in her bladder, in her groin, which can be an inguinal hernia, which is interesting, but they didn't find it, but it's suspicious. You can have arthritis in your hip joint. And if we're dealing with a compressed disc in the back, you could have nerves up by your spinal cord or down in your sacrum that are being compressed that could also be triggering some of these symptoms. So if you have persistent low back pain, it's always important, and especially if you've got sciatica, if you've got pain that shoots down your leg, if you have pins and needles, areas of numbness, man, we want somebody to really evaluate what I call the biomechanics of your pelvis. We want to evaluate your muscles, and we want to evaluate your nerves, because that's not driven by your bladder. Sciatica is not driven by your bladder. It is driven by muscle squeezing nerves. And last but not least, we need to talk, as somebody asked here, pudendal neuralgia. There is a significant group of patients whose symptoms get worse based upon body position. If you have pain when you sit down that gets better when you stand up, that's not your bladder. If you have pain that shoots down your leg, that's not your bladder. If you have pins and needles, areas of numbness, that's not your bladder. If you have PGAD, persistent genital arousal disorder, where you feel aroused sometimes randomly at the worst times, like when you're driving in your car or you're shopping or you're at work and you're going, where'd this come from? There's no reason for me to be aroused right now. And it's a painful, uncomfortable arousal. That's actually a pelvic floor muscle squeezing a nerve. So odds are you were sitting for a long period of time. So again, if you have pain when you sit down, that gets better when you stand up, or if you have pain when you squat down. I was working with two steel mill workers, one guy old and one guy young, and they both had pudendal neuralgia and sciatica, and it was associated with urinary symptoms, but they had that telltale numbness, pain shooting down their leg, and we sent them off to be evaluated by a pelvic floor physical therapist. And also there is something called peripheral neuropathy, also known as small fiber polyneuropathy, which I happen to have, along with diabetes. These patients might have burning, numbness, or tingling, what we call allodynia. Allodynia means that nearby proximal nerves start to hurt. So I went through a period where it wasn't just my bladder, anything, but if you just touched my skin below the waist, it hurt. That's a perfect example of one nerve irritating another nerve, and eventually it did go away. Or let's see, if you have areas of numbness, things like that, we want to look at nerve health. So the point that I'm trying to make here is, listen, my friend, we have learned a lot about IC in the last specifically 5 years. And for those of you who were diagnosed 10, 15, 20, 30 years ago, like me, and you have been living in this world where you believe that you're condemned to live with this incurable bladder disease, that's not the case now. Now we understand why so many patients never responded to therapy, because we weren't treating the right thing. And today your diagnosis begins with what we call your phenotype. What patient group do you fit into? So some patients have Hunner's lesions. Hunner's lesions have now been connected to viruses, a viral infection, along with a couple of other things. Many women have estrogen atrophy. And the doctor prescribes them estrogen and they stop using it. And a lot of women stop using it after they use it the first time because it burns. The reason why it burns is because your skin is so freaking dry. But that goes away. If you try any topical on your vulva and it generates immediate pain, what that means is the quality and health of your skin is poor. And the goal of the estrogen is to improve that. And you have to ride yourself through that burn the first week or two. And it will get better as your skin absorbs that estrogen and starts to make mucus. So burning is normal. And yet many patients, it just scares them and they stop. It happened to me. And first time I used it, I had burning for about 5 hours, but I knew to expect it and I didn't get upset about it. Second time I used it, it burned for about 2 hours. Third time I used it, burned for about 15 minutes. Now, it will only burn if I haven't used my estrogen. And honestly, I haven't used my estrogen in about 2 weeks. So I have to remember to use it tonight because it's probably going to burn a little bit. My own fault. Many patients' symptoms are being driven by old muscle problems. And generally, it's a series of traumatic injuries to the pelvis over time, to muscles over time. So it might have been that you were an athlete and you you fell a number of times. You might have been playing ice hockey, figure skating, gymnastics, football, riding bicycles. Generally, what we see is a series of little injuries over time that slowly just worsen the muscle health. I mean, every time you fall on your tailbone or fall on your tush, you suffer a compression injury. All of your weight lands directly on a small section of muscle and blood vessels and nerves. Why do you get a bruise? The blood vessel gets broken because you fell on it. So not only does the blood vessel get broken, the muscle gets broken. Injured muscles become tight muscles, and that tension persists. And in the end, how do I want to say this? You're thinking UTI. You're thinking bladder, 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 bladder. And you want bladder treatments. But the thing is that they just don't work. And you can do bladder treatments for decades and they don't work because they don't fix the underlying problem, which is tight muscles squeezing blood supply, ischemia. The therapeutic priority of physical therapy is to get the blood flowing again. Because when your muscles are tight, damn, they squeeze things. They squeeze the urethra, they squeeze the vagina, they squeeze the rectum, which is why constipation is common. Very hard to have sex when you got a tight vagina or a tight rectum, right? Underneath all that, they're squeezing blood supply significantly. And if you don't have good blood supply, your nerves are not going to be healthy and the tissues are not going to get the oxygen and nutrition they need to be healthy. So this is why patients who have a pelvic floor injury often have bladder wall sensitivity and diet sensitivity. I did. I was extremely diet sensitive. because my muscles were so tight. I was in an advanced state of ischemia. But once I did physical therapy and got the blood flowing and the tissues healed, guess what? I can eat anything now. Do you know what this is? This is lemonade. Now, granted, it's very dilute lemonade. I'm not an idiot. I'm 66 years old. I've got atrophy in my bladder now. But I can have all the things I couldn't eat for decades because I finally did the therapy that helped the most. If you have a cystoscopy and your bladder is healthy, like they see nothing wrong with your bladder, don't get angry. Don't get confused. I mean, yes, it's confusing. Celebrate it. You got a healthy bladder. This is great. Now we have to look beyond the healthy bladder to find the cause of your symptoms. And for most patients, it's muscles and nerves and not the bladder itself. All right. So let me go back to here. Listen, I can talk, my friends. I'm here to drink. It's really hot here. And so I was drinking a lot before the meeting. I'm probably going to have to get up and go to the bathroom shortly. Robin said, I had a microgen DX test. Your urogynecologist said it wasn't medically proven. You have Proteus mirabilis 90% and Enterococcus fecalis 6%. Robin says, how do you find a doctor that knows this stuff? You can call the company Microgen, and they have a list of doctors that will talk to you about what you've got. I mean, Proteus infections, let me look at it real quick. Hold on a sec. Which one was it? Was it Proteus mirabilis? Would you say? Yeah. All right. So let's look at Proteus mirabilis real quick. The rod-shaped gram-negative bacteria, famous for its rapid swarming movement and ability to cause complex urinary tract infections. It lives in water, soil, and the human gut, frequently triggering kidney stones and catheter-associated infections. So it's a major cause of complicated UTIs, along with kidney infections and wound infections. It creates an alkaline urine environment and can cause kidney stones to form. Frequently forms on biofilms on long-term catheters. And generally is treated with a fluoroquinolone like Cipro or cephalosporin, guided by the sensitivity results. So the next generation DNA urine test should have told you what antibiotics kill it. So 90%, that would be a fairly significant infection. And I think that's worth, if your urologist won't do it, then consider your primary care. Robin said, yes, they found stones, but they said they're benign. Yeah, stones are benign. They're just annoyingly painful. They're sharp. They don't feel good, and they block things, and that's bad. All right, let me come back over to YouTube here. I mean, to Facebook here. All right. So yet again, guys, for those of you on Facebook, please, if I missed your question, ask them again, because, oh, here, hold on. I had the condensed view on. Let me see if I can see them. No, I want the condensed view off. Okay. Lori said she met another gal on the Inspire app with blankets of polyps, directing her to you with questions. Thank you. We know that carpa polyps can grow after Elmeron used, and we are working on that right now. Denise said she had an MRI showing a 3-centimeter cyst at her sacral 2. Could that be my frequency and sensitivity issues? Yes, we would call that in all likelihood a Tarlov cyst. There is an article on that on our website that we just put up a month ago by the Tarlov Cyst Society. Hi, Gay. Nice to see you, honey. Dawn says, can the trauma of losing a child bring on IC? Mine started 20 years ago when my son was killed in a tragic accident. Oh, Dawn, honey, I'm so, so sorry. Grief is relentless and difficult and life-changing. And I'm so very, very sorry that you lost your son. And I truly hope that you feel him. I feel my lost relatives frequently, and that gives me some comfort. So the question is can the intense stress of grief trigger IC symptoms? And the answer is possibly. Possibly. Because when you're under stress, you are essentially in fight or flight. What does that do? That raises your heart rate, that raises your blood pressure, that tightens your muscles, that sensitizes your nervous system. And it's not like the grief ends a week later. You've been grieving for a long time, and it takes a toll. And so it may be that your nervous system has just become very, very sensitive. That wouldn't be a disease process. That would put you potentially in the widespread pain group instead. But the other thing we want to look on is, just getting older, estrogen atrophy. I can't tell how old you are by because your picture is really small, but we want to know that. Julie says she keeps hoping for cancer. A lot of patients feel that way, Julie, because when you get a diagnosis of cancer, you get sympathy. As horrific as a diagnosis of cancer is, again, since I am a cancer patient, that's really a reflection of the fact that you haven't gotten sympathetic medical care. Michelle says she's also sending another woman with increasing polyp load. Thank you, Michelle. Julie said, my mom smoked when she was pregnant with me and my dad died of bladder cancer. This is a real fear for me. What is the best test to take and what is the marker called that will be the one to pay attention to? Honey, it's just called a cytology test, a urine cytology test. That just looks for cancer markers in urine. I don't remember the name of the specific marker. And if you're really, really worried about it, you can ask the doctor to just look in your bladder, see if he sees anything. Listen, I believed that I was dying of cancer when I was diagnosed with IC. I didn't believe them when they said I had IC. My pain was so off the charts severe that I demanded exploratory surgery, and they did it. I had an exploratory laparoscopy to look for cancer. And I was shocked when I woke up in the recovery room to be told I was completely cancer-free. And now it all makes sense because now we know the neuromuscular origins for IC symptoms. Julie said, my mom drank when she was pregnant with me, and that is what caused my IC. Julie, I don't think we have any research that has ever proven that. But here's what we do know. Is that widespread pain group is driven often by childhood trauma. And a very, very common theme in our office and patients who have widespread pain is growing up in the home of an alcoholic. So again, we'll talk about that when you and I talk, okay? And here, hold on a sec. I just got a fire alert. I got to look at it real quick. Just bear with me. Oh, the fires are bonkers right now. You got to feel horrified for the patients up in Seattle, people up in Seattle right now who have lost 600 homes overnight. I was watching that last night too. Here, you know what? Oh, here it is. Let me just look at watch duty real quick because, man, these fires move fast, so I got to be smart here. The fire nearest me has grown a little bit. That's what that was about. Oh, okay. They expanded the evacuation. Okay. Well, that's not for me. Okay. Quick bathroom break. I need to urinate. I'll be right back. Alrighty then. I have returned. On a scale of pelvic floor tension, I give myself a score of 8 out of 10. What does that mean? It means that I was able to urinate easily. My muscles were not tight. That's pretty good. I mean, they're a little tight. They feel a little tight to me right now. Probably because I'm not sitting on my chair cushion. Here, hold on. I can't sit anywhere without this wonderful waffle cushion. Oh, so much better. So much better. Okay. Susan said, can you repeat what you said about well water contamination? My IC started years ago when I found out our well water was contaminated. Doctors all told me that that didn't cause my IC. I never believed that. I've always been convinced that it caused that. So the bladder, like any other part of the body, can be injured, and generally it's injured through chemical exposures. And anything like chemotherapy, chemicals of chemo can be damaging. The chemicals from cigarette smoke can be quite damaging, which is why it's the number one cause of bladder cancer, because they erode away at the bladder wall and turn things on that shouldn't be turned on. There is a condition called eosinophilic cystitis. So eosinophils are white blood cells. And so if they biopsy your bladder and they find your bladder walls filled with eosinophils, that usually means that your bladder is fighting something. Your body is fighting off something. Now, our body cannot distinguish between a bacteria and a chemical. Basically, when the bladder gets injured, it's hardwired to think it's infection. I mean, our immune system is designed to search out and kill bad infections. Our bodies weren't designed for today's toxic chemical load. So let's say you're going through chemotherapy or you're using ketamine, those directly damage the bladder wall. And now urine is going into the bladder wall where it is caustic and irritating. It's causing mast cells to release histamine. It's just irritating. It's irritating everything. Now, the bladder wall is not passive. The bladder wall sends out a variety of messages saying, help, 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 invader, invader, invader. And there's a very specific set of messages that the urothelium sends saying there is a problem. And that then triggers the immune system to swarm the area with eosinophils or lymphocytes. Just your body's army is coming to fight the invader. There is an invader. The cells are saying, help, help, help. The body responds by sending help. The problem is that there's nothing to kill because it's a chemical injury. And so what happens is that the white blood cells often swarm, especially if it's a really persistent chemical injury, like being exposed to, like really badly contaminated water that you're drinking every day. So it's just injury after injury after injury after injury, and your body's working really hard to clear the infection, but it isn't. So if they found that you had eosinophils in your bladder, that would potentially be a sign that we're dealing with a persistent chemical injury of some type. But here's the reality, Susan. Once you're away from the injury, healing is always happening. Like our body is wired to repair everything that happens to us. And so I would assume that any of the superficial damage that chemical injury caused is long healed now. The question is there a legacy to that injury? Is there neuroinflammation? Have the nerves in the area become sensitive? That's a possibility. That's certainly a possibility. So I hope that makes sense. Julie says she was diagnosed with endo. You're not the only one. That's why it's called the wicked twin to icy. Helen says, that's what I have. Everything you just mentioned, fibro and now vaginal atrophy. But the atrophy is not related to that. The atrophy is just atrophy from just not having estrogen. You're using Vagifem for 2 years now, but you're not better? Well, okay. So let's say, Helen, and by the way, I love the name Helen because my mother's name was Helen. So whenever I hear Helen, I have happy thoughts about my mom. Let's just say you're an atrophy patient. So let's just say that your symptoms started after a total hysterectomy, or maybe in your late 40s, 50s, or 60s when estrogen levels dropped. So think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of irritants. So how can the bladder physically hold ammonia for hours and not get damaged? How does the bladder protect itself? Well, the way it protects itself is with a really thick coating of mucus. So your bladder is like your mouth. It is a hollow organ that is very wet and slippery on the inside. And that wet and slippery mucus is a physical, robust, strong barrier that protects the bladder wall. Okay, but here's the problem. It's estrogen dependent. So what that means is that when you're young and have a lot of estrogen, your bladder can make a lot of mucus. But if you've had a total hysterectomy or you're on estrogen suppression medications for endometriosis or cancer, or you're just getting older, guess what? You don't have as much estrogen anymore, which means your bladder can't make as much mucus anymore. And this causes what we call atrophy. So you know how painful dry mouth is. When you have dry mouth, it's uncomfortable. Well, atrophy is dryness in the urethra, in the bladder, in the vagina, on the vulva. So our therapeutic priority is to try to get the skin healthy again so that it can make your own natural mucus again. Like the most natural thing you can do is help your body make its own legit mucus. And how do we do that? With estrogen. Okay, so you've been taking Vagifem for 2 years. For some patients, so number one, I applaud you for that. That's great because that does help your skin stay strong. But even with Vagifem, you're not 20 years old anymore. Some women need a little bit more help than that. And these are the women women who would benefit from a chondroitin-based supplement that helps to coat the bladder. It's kind of replacing what Elmeron, the real ideal market for Elmeron was an atrophy patient because Elmeron coats the bladder. Elmeron is a chemical Band-Aid, also known as pentosan polysulfate. But so it protects the tissue. Of course, now that it's associated with retinal disease and bowel disease, we're looking for other things that are less risky. And most patients have transitioned over to a chondroitin-based supplement like Bladder Builder or Bladder Rest. Those are the preferred things because chondroitin is a building block of the bladder wall. It is critical to the superficial integrity of the bladder wall. Now, in the old days, we suggested aloe because aloe can be soothing to the bladder, but there's no research that shows that aloe is beneficial to IC or the bladder that's ever been published in a peer-reviewed journal. And so let me just look again. I'm going to the National Library of Medicine right now. I'm typing in aloe interstitial cystitis. Is there anything? Nothing. In contrast, we have research that shows that chondroitin is helpful for some, but not all patients. So I would consider maybe doing something that might protect your bladder a little bit more. Also, hoping that you've had a proper phenotyping. You're absolutely welcome to give me a phone call this week and we can go through stuff because maybe there's something you're missing. Linda says, what about mast cells? Listen, there is definitely a group of patients who were allergenic cystitis, and we now have 2 formal phenotyping proposals, one from Canada, one from France, that say patients should be assessed for allergies. If you are an allergenic patient and you flare during allergy season and you have an abundance of mast cells, then the therapy for you would be an antihistamine. And I can give you the research for that. It's already on our website in the phenotyping area. Joni says, have you ever heard of anybody having a flare after a reclass infusion for osteopenia? My rheumatologist recommends it. I'm going to say I think so. I might have had 1 or 2 patients over the years, but not a lot and not consistently. Okay. Denise said the bladder is not sterile. Bacteria will be there. Absolutely. The bladder is not sterile. There's good bacteria living in urine, but sometimes pathogenic bacteria take over. Arlene said, how long after a hip replacement can you go to pelvic floor physical therapy? I don't know. Got to ask your doctor. I had somebody ask this morning, how quickly can you do physical therapy after a hysterectomy? Well, I wouldn't let anybody touch me there for about 6 months. Helen says, I would go watch on YouTube thinking about contacting. Yeah, honey, I'd be happy to talk with you. I'm always happy to talk with another Helen and another Heidi and another Jill. I'm happy to talk to anybody, really, quite honestly. Heck, I even answered my phone on a Sunday morning. There you go. Serena said, I'm stuck with a catheter after a hydrodistension. Please help. My urologist is being absolutely horrible. The pain is unbearable having this catheter in. I've had 3 trial voids fail. Serena, when did you have the hydro? Now, anytime you're sent home with a catheter after a hydrodistension, generally what that means is that something happened, that the bladder might have been perforated or injured, or maybe when they did the biopsy, it went a little deep and created a weakened part of the bladder, and they just really need to keep urine flowing so the bladder doesn't get stressed by having a lot of urine in there. You can call your doctor and ask them to use a much smaller catheter. It may be There's like two things that are happening. Number one, if you're having a lot of urethral pain, they may have just stuck a 40 French catheter in there that would be way too big for me. You can ask for a pediatric catheter. And then the second thing is if it's a Foley catheter, there's that little balloon up on the top, and that little balloon might be sitting on a very, very irritated bladder wall. You could ask for some pain medicine. And generally, the Foley is only kept in for 4 or 5 days. So hopefully it'll come out this week, but I would encourage you to be the squeaky wheel. And I'm wondering, did you have Botox when they did the hydrodistension? Did they treat you with Botox? Because that might explain why you're struggling to empty your bladder, because Botox can make it difficult to empty. Tiffany said, I have alkaline urine and bilateral kidney stones. Last year, you had 2 sepsis hospitalizations, no warning, no fever, nothing. After what was found on one of those microgen tests that you shared, has me thinking maybe I should have one at one point. Why not? It's data. It's data. The challenge with next generation DNA urine testing is it's the infectious disease specialists that are using it the most. Urologists and primary care doctors are very, very unfamiliar with it. They don't necessarily know how to interpret the results. And more importantly, health insurance companies kind of poo-poo it because they don't want to pay for it. But we have had kind of groundbreaking lectures at our national urology meetings, the American Urology meeting. Curtis Nickel just flat out, he was the top IC researcher in Canada, one of the best in the world. He just flat out said the future of urine testing is next-gen testing. There's just a little bit more we need to learn and a lot more training that has to be done to have doctors that are informed about how to do it correctly. Michelle said, did you say we should all get tested for STDs, precautionary, gynecologist annually if I want the test? Well, normally you're tested for STDs at the first appointment. But if you are, you know what I mean? If you're in multiple relationships or you've gone from one lever to another, then it's always good to get STD. You can actually even order some tests and do it at home too. Julie said Spokane is being horribly burnt. Yes, I think my ex-neighbor's home was burnt last night. Nicola said, I was told if your bladder isn't right, it can cause vulva pain. The heat isn't helping my vulva walls. The estrogen cream doesn't seem to be working. The vulva is throbbing and weird umbrella and cysts are appearing. Well, the bladder isn't going to cause vulva cysts, honey. That would be a real stretch. If you feel like your urine is hot, like as you're peeing, it's burning your vulva as it's coming out of your body, that's a sign of estrogen atrophy, that you could have atrophy on your vulva. The other thing, though, is there are different types of estrogen cream, some of which have preservatives in them that can be more irritating to the vulva. So for example, the brand names are pretty well known to be a bit more irritating because they generally have preservatives in them to expand their shelf life. Most IC patients that I've known prefer to get a compounded preservative-free estrogen cream that does not have the irritants in it. That's what my gynecologist said. He's like, I'm not giving you any brand name. You're way too sensitive. We're going straight for the least irritating estrogen cream out there. So I have to wonder, Nicola, if you're using a brand name, are you using like Estrace or Premarin? Maybe you're reacting to a preservative in it. Deb says, I was never told what caused my IC, but I have a cyst on my ovary that burst and it caused a UTI. Unfortunately, the doctor's office failed to tell me. And a long story short, I ended up having a UTI for over a month. It took almost 6 months to get my diagnosis because the urologist did the pat on the head and said he had to get up to P2, but he did a voiding test and was shocked. Then I had the cystoscopy with hydrodistension. They found lesions. I've been living with IC for over 15 years now. It isn't as bad as the beginning. I have flares, but I've learned to live with it. So, Deb, you've got Hunner's lesions. So Hunner's lesions are known for healing spontaneously. They're also known for growing more spontaneously. The real question is, what causes a Hunner's lesion? Well, we've got 3 theories. Theory number 1 is that proven in research and multiple research studies that they're caused by a viral infection, specifically Epstein-Barr mononucleosis as well as polyoma. So if you have a history of mononucleosis, there is a chance that that Epstein-Barr virus infected your bladder and caused the lesion. Theory number 2 is that it's a result of very, very inflamed nerves, maybe an autoimmune condition. And theory number 3, it is the result of something called posterior fornix syndrome, which is also basically very, very irritated nerves that have been displaced and pulled on by a damaged ligament. So my question to you would be, when was the last time you had a cystoscopy, and how many lesions do you have, and is it fewer or more than you had originally? Denise said you were diagnosed with vesicular cystitis, fluid-filled tiny bumps. I have a picture of that, Denise. Hold on a sec. This was new. So, like early summer or late spring, there was a doctor in Texas who, here, hold on, let me just find these pictures. I actually have the article for that too. Yeah, here it is. Hold on. I always have lots of pictures. Nothing. Okay. So there's the article. Yeah, here it is. Okay. So, you have to understand that technology is evolving. Our way of looking at the bladder, understanding how the bladder functions, normally, is always under study. We call this basic bladder studies. And there was a grad student, I think in Texas, who created a new way of looking at the bladder wall using fluorescence. And when she did that, something interesting was found. And I can show you this. So look at what she found. This is the bladder wall. And what's right on top of the bladder wall? Hello, bacteria. Isn't that interesting? Here is another picture. And then, so they call this FISH, fluorescence in situ hybridization. These are bladder biopsies before fulguration showing tissue resident bacteria. So, for decades, doctors have described trigonitis. Now, the trigone is a little triangular part of your bladder wall that goes from ureter to the urethra. And it's different than the rest of your bladder. In fact, that's where a lot of your hormone receptors are in your trigone. And so doctors have long described what they call it, a cobblestone-like appearance on the trigone, bumps. And I remember when I built the IC network in 1994, I was 34. Man, I dove into all the trigonosis research because I just wanted this comprehensive website dedicated to all the causes. And back then, half the doctors were saying the bumps were normal. Half the doctors were saying, no, the bumps were abnormal. But the general consensus of the time was, you don't need to do anything about it. Bumps are fine. Well, and so here are pictures of the bumps. You see this? Which I think your doctor is calling vesicles, right? So you see all these bumps right there? It's not smooth, it's bumpy. Well, when you cut the top of the bump off, what do they find? Pus. They're little superficial pimples. They're pimples. And again, you can see the bacteria right on the surface of the bladder wall. You can see them. So this doctor in Texas took these results and made the direct correlation, and I've got the article right here. And let me, here, hold on a sec. Okay, so see, I've got it all highlighted. I'm a geek. I like to read this stuff. So, why do patients keep getting a recurring infection? They're no longer sexually active. I examine them. I see nothing normal. They have no prolapse. I do post-void residual. They empty their bladders properly. I check the upper tract for kidney stones. I see nothing wrong, and I study the bladder, even when as far as doing x-rays, and I see nothing that would explain it. So where are these infections coming from? At this time, I had the chance to read the literature and stumbled into this wonderful work of Scott Holmgren, who's a microbiologist who had worked on trying to understand more about bladder infections. He was able to understand how bacteria attach to the surface of the urothelium. Yada. Okay, we know all that. Okay. I started to notice more and more that these patients often had trigonitis, which is an inflammation of the trigone. And the trigone is an ideal spot for infection because bacteria obviously send up the urethra, and they kind of anchor themselves to the trigone. It does not have to be a lot of urine like the rest of the bladder. It's a very welcoming and folding urothelium, so it's ideal for bacteria to attach. And you typically see them between each of these orifices in the bladder neck. Okay, and here are some obvious classic examples of pus pockets, chronic infected stones, and a lot of cystitis cystica, which is what we call it. What you see in green in the center, which is this slide, right? That's the bacteria. So what he did, okay, so hold on a sec. So his big turning point in preventing recurring infections, so they found the infection, they found the little pus pockets on the bladder wall. And he could see it. They could cut them off and pus came out. So there was absolutely, it was very, very clear. These were basically very, very superficial pimple-like structure. So what he did is he fulgurated them. He fulgurated the trigone. And so fulgurating means he cauterized it. And when he cauterized it, something amazing happened. The areas that he cauterized never got infected again because when you cauterize it, you destroy the cell that the bacteria normally attaches to. So here, hold on a sec. The infection never recurs in the same location because the surface ligands change. There's no longer uroplakin 3A here for bacteria to attach to. So that's on the side, but that's important to realize that once you cauterize, the area you cauterize will not have infection ever again in that spot. This is done as an outpatient procedure, light anesthesia. It's a surface procedure. He uses what's called a Bugbee electrode. So he said, very much like if you have pimples on your face, you don't want to damage it below anything in the surface. So it's very surface driven, below the surface. So you're just working on the immediate surface. Takes less than 30 minutes. After that, you have to manage the reaction to the burning, which can cause some emergency and frequency and almost feeling like you have an infection. If it's intense, we recommend patients limit fluid intake to rest their bladder. Don't go home and drink 5 gallons of water. That doesn't work well for these types of procedures. They usually use azo and anything to control bleeding. And they say he puts them on low-dose antibiotics for the first 4 to 6 weeks that they then discontinue. But he does say here, don't go back and look again for another 6 months. It takes the bladder 6 months to heal from a fulguration. So don't look before 6 months. It's not going to be used. It's going to be useful to your patient. And the reason you look at it 6 months is just to make sure that the way you cauterize is healed. Very importantly, to make sure that there are no new lesions that have appeared. So before you declare the patient cured, go back endoscopically if you don't mind. Use your flexible scope to look at the top of the trigone, and let's see if it's gone. So, you didn't expect that, did you? Here, hold on a sec. I got to scroll back here. So, Denise, vesicular cystitis, the tiny bumps. So you would potentially, I can give you this research study. The treatment, according to this guy, is to just cauterize the bumps and you should never have pimples again there. Hey, Brandon, nice to see you, dude. Hope you're doing well. Your hydro was helpful and so was your nerve block. Excellent. Hello, Kayleen says, I didn't get the notification until now. You went to the doctor on Thursday. Found out you have chronic migraines. I guess there's a connection to that with IC and vulvodynia. Yes, honey, that's part of the chronic overlapping pain conditions, widespread pain. IC, IBS, vulvodynia, TMJ, migraines, hello, fibromyalgia. So that pretty much puts you in that widespread pain phenotype, which I think, knowing you, makes a lot of sense. Nicola says, can you buy Bladder Builder in the United Kingdom? The answer is no. And we cannot send it to the United Kingdom because of Brexit. So your only hope here is to make friends with somebody here in the United States and give them the money to buy it for you. We will ship it to them and then they can ship it to you, but we cannot ship it to you. Nicola said, what is phenotyping? Phenotyping is trying to figure out what group you're in because we're not all the same. For some people, IC begins in childhood. For others, it begins after menopause with the same diagnosis of interstitial cystitis. But are we really the same? No. For some people, IC begins when they're going through chemotherapy because the chemicals of the chemo damage their bladder. While for others, IC begins after they fall on their tailbone or having a baby. Again, same diagnosis of interstitial cystitis, but are we really the same? The answer, of course, is no. And you really see the differences when you look in the bladder because some people have big visible wounds in the bladder, but the rest of us usually don't. So there are very distinct patient groups. And our goal now, we don't just tell everybody you have a bladder disease and give you a medication and send you on your way with a diet. That's not going to work. We want to find the underlying cause and treat the underlying cause. And we do that with phenotyping. I have a big video on this and a huge section of the website on this. icnetwork.org. Go over there in the interstitial cystitis section. You can read all about phenotyping. And if you watch our free IC 101 masterclass, it's episode 4. Arlene said, are there antibiotics that I see friendly? After hip replacement, I need antibiotics before dental work. Yeah, things like Keflex are usually more friendly than Augmentin. Augmentin is probably the most notorious for being irritating. Helen Sims says, I got pelvic floor physical therapy. She said, I have lichen sclerosis, so you're going on sclera. Yeah, lichen sclerosis is very common. It is a essentially kind of an autoimmune disease on your pelvis. Your skin gets very, very white and pale. I really think tight muscles plays a role in that, in cutting blood supply to the vulva. But the treatment is generally clobetasol and typical vulvodynia strategies, making sure you're not, like, for example, you shouldn't be wearing anything with fabric softener, because the chemicals in fabric softener that's left in your underwear, it's going to really irritate the lichen sclerosis. You shouldn't use wipes like Cottonelle. They're actually fairly well known to be a bit irritating for patients who are more sensitive. You might even have to change your laundry detergent. Typical brand names tend to be a lot more irritating than, say, 7th generation free and clear, which is what I use, or 7th generation for gentle skin, because I'm very, very sensitive down there myself. So you are doing everything you can to protect your vulva right now, because it is very, very inflamed, and that clobetasol is kind of the number one treatment for that. Just make sure you don't put any more chemicals on it unnecessarily. Coconut oil. You want to, if you are in atrophy, if you're older and you're in atrophy, so your skin is very, very dry on your vulva, and now urine, every time you pee, is irritating that skin. And then God forbid you be wearing underwear with fabric softener, or God forbid you be taking bubble baths or using bath salts. Anything that's pushing a lot of chemicals on this dry skin is going to massively, massively inflame it. And so making sure your skin is healthy is really important. So that means using estrogen if you're of age and doctor says you have atrophy. But you can also use something like coconut oil. Just get a really high quality coconut oil. The challenge with coconut oil is it's pretty messy. It will soak through your underwear. Here in the States, we use something called vulva balm. So this is our vulva balm. And just to kind of show you what it looks like, it's like a really light, it's like a really, really light Vaseline, but it's not made from petroleum. It's made from avocado, sea buckthorn, and olive oil. And it very closely mimics your normal mucus. You can use something like this every day just to protect that skin. You don't want to have dry skin, because every time you pee, that urine's going to irritate that vulva. You got to give it protection. And so that's important. And we can ship to Canada for sure, but we cannot ship to the United Kingdom, or supplements at least. And by the way, we're in the process. We're building a brand new store that's going to massively improve our international shipping. Our old store is deprecated. It's updated, but old software that doesn't do a lot of new things. And so we are paying now for everything to be updated. They're doing test orders right now. Hopefully that will launch by the end of August, but it is a journey. And it is an expensive journey to update. Helen says she's only had her husband of 50 years. Congratulations, that's wonderful. And he's in remission of non-Hodgkin stage 4 cancer since 23. He's 72, and I'm not able to have intimacy, and my anxiety and depression is really bad. Well, Helen, here's the deal. We've had 2 sex therapists come and speak to our meetings. And one of the most powerful ones talked about how intimacy changes as we get older. So when you're in your 20s, intimacy and sex is very quick. It's like, get in there, do it, get done. There's not a lot of intimacy and caressing and stroking for a 20-something. They're more slam bam, thank you, ma'am, let's just get her done. And I mean, not to be blunt, but we all know that that's true. But then as we get older, we enter our 30s, we start to realize that sex is a lot more than intercourse, that there is affection, that there is joy, that there is far more than just a penis and a vagina, or whatever your pleasure is. And so what she said is everything becomes inverted as we get older, that as we get older, it's less about intercourse because we've got bad hips and dryness. It's more about affection and stroking and comforting and outer course. And so we had the other sex therapist who came to my local group. It was hysterical because one of my co-leaders, Evelyn, found a instructor, a gynecologist who was an instructor in sex education at the medical school at UC San Francisco, University of California, San Francisco. Very prestigious medical school. And we're like, yeah, man, we want a guest speaker on sex. And we invited him to come to our meeting. He's like, sure, be happy to be there. Well, we all got to the hospital where we had the meetings, and we're just waiting. And in walked Santa Claus. He looked exactly like Santa Claus. He had gray hair, he had a big beard, and he had a bowl full of jelly. He had a big old belly. I mean, legit, he looked like Santa Claus. And we all just kind of looked at each other and went, he's the one who's lecturing us on sex? And it's like, yeah, he was awesome. He was so good. And he told us this absolutely amazing story. Because as he was describing, what does intimacy mean? What does sex mean between couples, and yada, 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 and how every couple has their own journey, and every couple has to listen to each other and talk to each other about what's fulfilling and what's not fulfilling. Anyway, all that sort of stuff. He goes, so I've got this couple that I've been helping for years. And I envy them. They have the most loving sexual relationship I have ever in my life witnessed in a couple. Like, I don't know why they keep seeing me, because I envy them. My sex is not as good as their sex, that's for sure. And we're like, and he said, but their story is a very interesting story because he was in the war and he suffered a catastrophic injury in the war. A landmine took off his penis. So his question to us was, how can a man without a penis have a sex life that every other man envies? And he said they became masters at outer course, also known as tantric sex. So what is outer course? Outer course is where Your goal is to, through touching and stroking and licking and whatever you're going to use, to get your partner right to that point right before orgasm. You know, that point that it's just, it's like, it's so good and it's so short. I mean, sometimes you might make it last for 30 seconds or whatever, and sometimes it's there and it's gone because you orgasm that fast. And he said the goal of tantric sex is to get your partner to that point and then keep them there for 30 minutes. Then you back off and then you stroke and then you back off and okay. And if orgasm happens, great. If ejaculation happens, great. If it doesn't happen, the couple doesn't care because it feels so good. And he said, this is a couple who became an absolute master at that. And he reminded everybody that here's the deal. Men get prostate cancer. Women get pelvic floor dysfunction. Women have hysterectomies. There is going to come a point in time when that couple may not be able to physically have sex anyway. So how do you express your love? How do you express your love? There are sex toys for men. There are sex toys for women that are great, like the fleshlight for men. The Tenga for men, very, very popular if you have a wife who cannot have penetration for one reason or another. And I think the most important point that he emphasized to us, that I have emphasized to patients for 25 years, is that when your partner comes to you for sex and you just can't do that because you're in pain, you have to qualify it and say, honey, I would love to have sex with you. But right now, my body says I can't. My pelvic floor says I can't. My prostate says I can't. But that doesn't mean that I don't love you. I adore you. And so you have to remind your partner that you're not rejecting them outright. You're saying, I love you, but right now my body says I can't. And so for the woman, if you've got messed up pelvic floor and you do not want a penis down in your vagina, this is when you pull out a Tenga, a sex toy. Or you do other things, oral sex or tantric sex. So anyway, we have more information in the ICN sex area over on our website. But those are absolutely true stories. And the blessing here is that a couple that communicates just honestly about how they're doing is great. Now, I had a couple in my group, Chuck and Joe, and they have since passed away, that I adored. I knew them for many, many years. And actually built their website for their business back before I was doing IC full time. They came into our Christmas party furious. Man, they were raging angry at each other. Like, okay, everything's stopping for a moment. Joe, Chuck, what's going on? Because they were just spitting fire. And Joanne said, he doesn't even love me anymore. He won't even give me a hug. And she was like crying, like he doesn't care anymore. He doesn't love me anymore. And there's Chuck. And let me tell you, Chuck was a gem of a man. He goes, I don't know when I can touch you because every time I try to give you a hug, you push me away. And, I mean, the despair in their voices was real. And let me tell you, I was on that day. Handled it really, really well. I'm very proud of myself. I handled it well. And I said, now, Joe, is that true? Has he tried to give you a hug and you pushed him away? She said, yes, of course. And I'm like, well, then how does he know when it's safe to touch you? And that's when she said, he should know. He should just be able to look at me and know. And I was really blunt with her. And listen, I mean, everybody in the group knew each other. We were all friends. There were like 30 people there. It's like, now, Joe, that's not fair. He can't read your mind. He cannot read your mind. If you need a hug, you need to say, honey, would you please give me a hug? And she was just like stunned. It's like, oh, yeah, I can do that. And I'm like, yeah. And it was such a powerful moment for all of us who were there, just to remember that we cannot read our partner's mind, that we have to communicate. And if you need a hug, if you have a need, don't expect it. And the other thing to understand too is that they can't read your mind when you're having a flare. They've never had a flare. They don't know what it feels like. You've told them that you're peeing all the time. They can see that you're peeing all the time. You've told them that it hurts. But fundamentally, in the end, they have never experienced it. And the other thing you've got to be really clear with your partner is you cannot, if you're home having a wicked flare and your partner's at work, and your resentment is building and building and building and building, and you're so freaking angry that you are having this flare right now, and the doctor is not returning your phone call, and you don't know what to do, and you are a combination crying, angry, bitter, furious, and then your husband or your partner walks in the door and you slam, you hit them with everything, full gun, full arsenal. I am miserable today. And you're yelling at them because you're legit getting that stress out. You have to understand that they don't know what to say to you. You cannot dump it all on your partner once a day. This is where you have to have IC buddies. So you can call your IC buddy and say, man, I made the worst mistake last night. I made black bean soup and it just killed my bladder. Or I had a glass of wine last night or whatever. If you're having a flare, make sure that you have somebody else that you can talk with. You can call me. It's okay. Go to a support group. It's okay. I understand. I'm not really liking online support groups right now. I think the groups on Facebook and Reddit are not doing particularly well in terms of supporting patients. But if you need to go vent, go vent. Find another way to get your anger out. Don't take it out on your partner. If you need to journal, journal. If you need to get in the shower and scream, scream. If you need to go find a train going by so you can scream, do it. Don't take it out on your partner. It's not fair to them. All right. Let me go back to the question. Helen says, are you too old for HRT? And you're never too old for HRT. And yes, you absolutely can phone me. Denise said, I had 2 fulgurations. Problem is the bumps keep coming. Texas doctor performed it. Okay. So I would be very tempted to add lactoferrin because lactoferrin might boost your body's ability to fight infection. We've got good research with lactoferrin and IC. Chloe says, do I have a recommendation for coconut oil? No, I don't in terms of brands. I mean, you would just get like an extra virgin, expensive coconut oil. But again, the problem with coconut oil is it soaks through everything. It will soak through your underwear. It will soak through your pants, and you will be walking around with an oil spot. And that's what happened to me, which is why I only use Vulva Balm, because it does not soak. Here it is, Julie. It is on the IC Network website under Feminine Hygiene. Vulva Balm. Please buy it from us because that's what pays my bills so I can do these meetings. Do not go and buy it on Amazon. Please buy it from us. That will help me. It will help the IC Network work. There's nothing worse. I'll do a little tiny vent. I worked with a patient 2.5 hours this week. She was in horrible shape. Everything's free. Everything's free for moments like that. If you're calling in crisis, I am not going to ask for money. I didn't expect it to last 2.5 hours, but she needed a lot of help, and I happily gave it to her. But there is just nothing more disconcerting than spending a big chunk of time time with a patient, and then we talk about a product like this, and I go, could you please buy it from our website? And they're like, no, I'm going to buy it from Amazon. I'm like, I just gave you time. It's like we have bills to pay. It's that simple. Okay, Kayleen said, I'm still in pain from the clitoral lidocaine injections. I had the bladder instill on Wednesday while he was okay. Wait, and he pressed on that nerve a little. Keep getting cramps and needle feeling. I'm worried that my gynecologist poked a nerve. Yeah, it's gonna heal, hun. You're already living proof that nerves heal. You just got to give it time. Chloe was like, wow, yeah. Now I told her, I said, man, you just got the longest coaching I've done this year, if not, I think in the last 10 years. And I was happy to do it. No regrets. No regrets at all. Life is short. I figure, if you can look yourself in the mirror at the end of the day and be proud of what you've done that day, that is a good day, my friend. And I figure if I can help at least one person a day, that is a good day. All right, let me go back to YouTube here. You guys on YouTube, you're being so good. Alice 69, it's a different language. I don't know. Dolphin said, no infection and no cancer. What would be the cause? I have to get an ultrasound. My surgeon said she wasn't too concerned. Well, that's good. I mean, if there was no infection and no cancer, that's great. We've ruled out the really important things. Now they have to finesse the diagnosis. Robin said, thank God for you, Jill. You've been through it. I do believe my 6 abdominal surgeries have something to do with my pain. Lots of tethered scar tissue. Absolutely, honey. I'm not surprised. Robin says she wants a waffle. It's over on the IC Network website. We have 2 different ones. We've got the original waffle that's like $35, and then we have a new waffle from China that's like $15. I'm sitting on the China one right now, and honestly, I think it's a little better. Definitely stronger. Robin said she had a hysterectomy at 38, 1 ovary spared back in 2008. They didn't think we needed estrogen after. Exactly. Hey, listen, you got to understand that this is where, and Kayleen, girl, I'm talking to you, we all have to be invested in women's health and women's rights. Because a lot of research was preferentially targeted at men back in the 50s, 60s, 70s. And it's only in the last couple of decades that women have been getting more productive research into women's health issues. But it is a slippery slope. We are falling right back away. We're falling right back away from women's health. A lot of women's health studies got defunded and shut down. Listen, I was part of an IC grant. We were funded 2 months before the election. It got canceled. Man, and we had big plans for more research with that. What they are telling grant writers is don't submit a proposal that says women or talks about any other politically charged issues. So right now, women's health research is very small, and we have got to fight for this. We deserve that research. And I'm very, very upset with what's happening with health research right now. It is a shadow of what it was. And we have fallen back 20 years, 30 years in where we were a couple of years ago in terms of advocating for women's health needs, you know, and it's just I was talking with another patient. In my lifetime, I'm 66. Okay, so I was a teenager in the 70s. I was in my 20s and my 80s. The number one cause in my lifetime was women's rights. You realize that when I was born, a woman couldn't get a credit card without the permission of her husband. And yes, it took a lot of painstaking work and criticism from people who did not believe that women needed a credit card, or that women should vote, or that women needed health insurance. So all I'm going to say, I'm not going to get political. I'm just talking about women. Ladies, we got to unite and make sure that our needs are being represented, because right now we're being screwed. And it is very scary to see what has happened right now to important IC and women's health needs. So please support each other. Please think about other women who need help, even if you don't need help. Let us support each other as much as we can. Yes, exactly, Chloe. Exactly. We are the supermajority. If women actually united, we could control every single election. The problem is they keep us divided. I have 2 bumper stickers on my car. Billionaires are not your friends. And it's not left or right. It's rich versus poor. It's top versus bottom. And right now, the top are winning. And the rest of us are being thrown to the side with diminished healthcare, diminished research, diminished everything else, while the billionaires are doing whatever they want to do. And it is disgraceful what's happening. And it's been happening for decades, by the way. This didn't just start recently. I mean, this goes back 20 years. So anyway, all right. What have I missed? Have I missed any other questions? Let me look here. Okay, so again, Facebook is just not letting me scroll backwards. I am sorry. So if you asked a question on Facebook and I didn't answer it, don't take it personally. It's just technology. Ask it again. All right. Because I can only go back just a brief period of time on Facebook right now. It sucks, but Facebook's always been that way. Robin, me too, girl. I love where I live. I'm a California girl all the way. Born and bred here in California. For those who want to call me, I will put my number. There it is on Facebook. Now let me put it on YouTube. And the way the phones work is it's first come, first serve every morning. So like this morning, I started at 7, about 7:15. So if you call and I text you back, I can't talk right now, or can I call you later? That just means I'm already working with somebody. So just be patient. I will do my best to call you back. If you don't hear from me in a couple of hours, please feel free to call back. Please know that I'm in California. If you're on the East Coast, it's 8 o'clock for you and 5 o'clock for me. I might call you at 8 o'clock. Okay? So I do my best, but it's first come, first serve. And I always end those conversations with, if you found this conversation helpful, please think about becoming a member of the IC network or making a donation. Listen, I never go back and look. I never go back and say, hey, I talked to Jill and did she do this? I never do that. I've never done that. I never will do that. I'm just planting that seed that hopefully you see some value. Cynthia said, that's for sure. I lost my Medicaid. Oh, not even get me started. Julie says, amen to everything that you just said. Yeah, Catherine said, do I recommend getting blood work to check your estrogen levels? I'm on progesterone, estrogen, and vaginal estrogen. Not really. It's really about, what does your skin look like? I mean, because they can see atrophy very easily on your skin. And so you don't necessarily have to pay to have a blood test. And it's also about your age too. So listen, if you're 55, 50, 55, you're in atrophy. I mean, as soon as your periods stop, you're going to go into atrophy. And it's just, as you get older, it's just going to get worse and worse. I mean, I've worked with some ladies in their 80s who have vulvas that are like dry potato chips, and they are in absolute agony. That skin is meant to be moist. If it is dry, it's going to hurt and be uncomfortable. It is meant to be moist. And that's why vulva balm is so useful, because you can use it every day. All right, what did I do to my hair? I did something weird to my hair. All right. Here, hold on a sec. You know, it's like 104 outside right now. I think it feels really hot. It was hot yesterday. Okay, is my hair decent? Okay, so we have been going for 2.5 hours. Our next IC Optimist magazine is at the typesetter right now. It's going to be a gangbuster of a magazine. We do our best work. I certainly do my best work in our magazine. And let me tell you what the articles are. I have them right here. I've got an article on all the confusable diseases, on another article on common chemical irritants for the bladder. I've got a great summary of the two new sets of IC guidelines from Europe that are not bad. They're quite helpful. What doctors miss about men is an article. I've got an article on regenerative medicine, an article on the latest research with IC, an article on, interestingly, a hidden cause of UTI. You know what? Let's talk about that. So, here, hold on a sec. Let me open this up right here. Okay. So, when you think about recurring UTIs, you know, we're really thinking about who is more prone to getting recurring infections. And that's going to be somebody in atrophy, but it's also potentially going to be somebody who has a compromised immune system. Like a patient I was working with today was being treated for cancer, and she was on immunosuppressant drugs. And in fact, she was struggling with many, many recurring infections because her immune system was just not very, very strong. But a patient called us and they found another cause for her recurring infections: non-alcoholic fatty liver disease. There is growing evidence that fatty liver disease is associated with a higher risk of recurring UTIs, although the fatty liver itself does not directly cause the infection. But here's how it's connected. People with fatty liver disease often have insulin resistance, type 2 diabetes, or prediabetes. They might struggle with obesity or metabolic syndrome. Each of these conditions independently increase the risk of UTIs because they can impair immune function and increase glucose in urine, which then promotes bacterial growth, as well as altering our microbiomes. Fatty liver is associated with chronic low-grade inflammation throughout the body, which can then increase your susceptibility to recurring infection. And a new area of study is the gut liver bladder axis, AXIS. People with fatty liver disease often have changes in their gut microbiome. And since many UTIs are caused by bacteria such as E. coli that originate in the intestines, alterations in the gut microbiome can increase the likelihood of recurring infection. So for people with IC, recurring UTIs can complicate the diagnosis because infection and flares often produce similar symptoms. If someone has both, it's worth evaluating their blood glucose levels, whether their bladder is emptying completely, their vaginal health after menopause, and their kidney function. And practical suggestions that will decrease the risk or reduce the risk of recurring UTIs and ICs are going to be, and fatty liver disease are going to be, maintaining and achieving a healthy weight, which is really hard, improving blood sugar control. Like, I don't eat any sugar now. Regular physical activity. I am at the gym every other day. I walked 2 miles yesterday and then did weights. Eating a diet rich in vegetables, fiber, and healthy fats while limiting refined sugars. That's my diet. Staying well hydrated. And if you have UTIs, getting them checked consistently and regularly. The bottom line is fatty liver disease doesn't directly infect the bladder, but it is associated with metabolic and immune changes that can make recurring UTIs more likely. If a patient has both fatty liver disease and recurring UTIs, it is reasonable to evaluate for insulin resistance, diabetes, bladder emptying problems, and other metabolic conditions that can be contributing to both. So that was new. That was a new thing I learned. What else do I have here? It's a big, an article on, listen, you know what? I kept the urethral stricture article out. Anyway, it's going to be a big article. I mean, big magazine this year. Summer food, summer fun. What else do we have? Yeah, that's about it. Lots of good things happening, my friends. Lots and lots of good things. Arlene says, how do you get compounded estrogen cream? You look for a compounding pharmacy. A compounding pharmacy is a pharmacist that has an extra certification to make medication directly. So they're not just distributing pre-manufactured meds. They're actually making meds. So a compounding pharmacy often does like a compounded estrogen cream or compounded skin cream. So virtually every town has a one or two or more compounding pharmacies. And ours, it's a company, it's the Dollar Drugstore is one. I get mine from the Women's International Pharmacy in Arizona. Julie says, where in the IC network can I find a link to locate a urogynecologist near where I am? It's in our Find a Doctor area. Just go to the IC main pull-down menu and you'll see Find a Doctor, and that will take you to a database where you can put your zip code in. I'm going to tell you right now, maintaining that list is very, very difficult and very, very time consuming. Doctors retire, doctors leave, other doctors come up. This one thing I would probably take off our website is our doctor list. I'm going to say it's probably 50% accurate. We go through it every year to confirm that doctors are still where they are. We try to always ask for new doctor recommendation. One of the things that I tell patients, that a sneaky way of finding a gynecologist or urogynecologist is actually asking your physical therapist who's referring patients to pelvic physical therapy. That's a good clue as to who might be more informed. Okay, somebody just had a message there and they just deleted it. It's okay to ask it again. I saw it and then it disappeared. Let's see. Okay, so again, go to icnetwork.org, and hopefully on a computer, not just on a phone, because it's a massive website. Navigating it on a phone is very difficult. You want to be on a computer or an iPad. Go to the interstitial cystitis. It's a first link in the main menu, and you'll see find a doctor. And understand too that, listen, local doctors are going to be the least trained in IC. They're not going to see a lot of patients and pelvic pain. They're not going to have seen a lot of patients. They're not doing research. Odds are they're not going to the conferences, nor are they taking the classes. So it is very possible that your case exceeds the skill set of your local doctors. So if you've already gone to 3 or 4 local doctors and you're not going anywhere and they say your case is too complex, your next step is to go to a regional doctor. These are doctors normally at universities. So you can ask for a referral for a second opinion. You can ask any doctor for a second opinion. You might have to juggle some hoops to get it approved by your HMO or your health insurance, but it's very normal to get second opinion. So universities are generally where those regional doctors are. And, because they're going to conferences and they're getting all the complex cases from the surrounding area. But you can even exceed their skill set. And that's when you go to a national specialist. And that might mean traveling. But it's worth it. What was that? I just heard something. Oh, it's my neighbor opening his back door. I was hearing squeaking. So we have a list on our website of some of the top national doctors. Our challenge is that golden list that we used for many years. Half of those doctors have retired now. So we're trying to find those new doctors, and that is difficult to find those new doctors. Arlene says, how long does it take to have a bladder flare after eating a somewhat questionable food like watermelon or sardines in olive oil to know if it's causing the flare you had? Well, I don't know why sardines and olive oil would trigger a flare. It shouldn't. Watermelon does bother some patients, but certainly not all patients. The worst flare, the single worst flare there were so many, but the one that I remember the most back in the day was I had gone with my boyfriend to see a Harrison Ford movie. And I ordered a fountain 7-Up. But it wasn't a 7-Up, it was a Sprite. So it wasn't out of a can. It's where they make it. They have the syrup and they have the sugar and they have the soda and they make it at the movie theater. And it was insanely strong. And I was crying 20 minutes later, 30 minutes later at the most. I've never been in so much pain after drinking anything than that improperly made fountain drink. And so it takes about 30, 45 minutes for something you've drunk to reach your bladder. And that was true for me. And then the more it got in the bladder, the more awful I felt. So I was running to the bathroom in the middle of the movie, and then I hung out to the very end, and I just said, I've got to go. I've got to go. And I got to my car and I just sobbed all the way home. Yikes. I'll never forget that. And he gave up on me. He thought he said, listen, I watched my mom die of cancer. I can't watch you die either. And he broke up with me. Ooh, that night or that day. Brutal. Michelle says, advantage of using compounding pharmacy for estradiol cream or through your OBGYN. Well, your OBGYN is still going to order it through a compounding pharmacy, hon. I mean, unless the OBGYN is making their own meds in their office, generally they send the prescription to a compounding pharmacy. The real question is, what's the advantage of a compounded estrogen versus a brand name estrogen? And the answer is preservatives. The brand name estrogens tend to have a lot of preservatives in them, which can be very, very irritating. A compounding pharmacy can remove the irritants. And I get mine from the Women's International Pharmacy, which is now known as the Belmar Pharmacy, and I've never had a problem with them at all. In fact, I need to reorder. Dolphin says here on YouTube, vaginal estrogen cream saved my life. Exactly. Exactly. You know, we just have to get that skin healthy. And there are, I believe, millions of women who have been told they have a bladder disease when they don't. It's just atrophy. The bladder only knows one language: frequency, urgency, pressure, pain. The only way that the bladder can tell you there's a problem is by making you feel like an infection. A bullet wound would feel like an infection. A stab wound would feel like infection. Everything feels like infection, even if it's not. So urine on dry, irritated skin is going to hurt and potentially make you feel like you have an infection. Plus, when you're in atrophy, you're going to be way more vulnerable to infection anyway, because your skin's not strong enough and healthy enough, and there's not that protective barrier to push bacteria away. So there you go. All right, guys. Well, listen, I think that we have come to the natural end of this meeting. I hate to leave because we've still got, well, we got 30 people here. Listen, I am happy. I'm happy to stay as long as you want to stay. I just need questions. You're welcome, Chloe, and I hope you enjoy the rest of your weekend too. What am I going to do tonight? Where I already have my rotisserie chicken for dinner. I am going to paint and watch the BTS concert from Newark because I am Army. Proudly, I love BTS. What are you guys going to do tonight? You're welcome, Carlene. You're absolutely welcome. And I'll be back at it tomorrow morning. I'm rebuilding our IC 101 website really quickly. That should be done tomorrow. And then we're trying to finish up our new pain guide. Oh, and let me show you this, guys, just so you know, because I think we have new people here. So please know that we have our publications, such as our IC 101, bladder disease. It's not just a bladder disease book. New cover, guys. I've skinned everything. This is the very first book ever that wrote about phenotyping. I was right. We were right. And we continue to play a very good role at kind of predicting where doctors are going to go. All right. And then the sister books to this are our diet guide, new covers. So if you're struggling with food, especially if you're a Hunner's lesion patient, you just don't know what's going to work for you in terms of food. You're not sure what to eat when you go out. You're not sure if you can even go out. You're not sure about spices. You're not sure about international foods. That's all discussed in our diet guide. And then, oops, we have our flare guide, which talks about 9 different types of flares with rescue plans. So a bladder wall flare, pelvic floor flare, a stress flare, a hormone flare, a vulvodynia flare, a urethral flare, a rectal flare. It gives you triggers and it gives you rescue plans. And again, this is the brand new cover released last week. I love these covers. And then, if you didn't know it, we have a new app. This is our 3rd app for IC. And let me show it to you. Let's see if it'll, here, hold on a sec. My screen is, of course, here, let me clean out the screen for my iPad and then I can show you what it does. Don't want you to see all my fingerprints on my iPad. Okay. So this is on Android and Apple. And you can see here, it is a little watermelon slice. So it's called the IC 101 food app. So you see that watermelon slice right there? Right there? That's it. So when you click on that, it immediately goes to our proprietary database of foods that we've created. So you're first going to see categories: fruits and veggies, grain, dairy, meats, veg. And I know it's kind of hard to see on, it's very hard to demo something on a computer from an iPad because of the glare. So we can click, let's say, the dairy group, and then it's going to give you an alphabetized list of foods. So butter and margarine, buttermilk, cheese. So let's go to cheese. I'm clicking on cheese. And now in the cheese group, it has bladder friendly, which is American, mozzarella, cheddar mild, feta, ricotta, and string cheese. It's got cheeses that are worth a try that most patients can tolerate, but you got to be cautious with them. Blue cheese, brie, brick parmesan, camembert, sharp cheddar cheese, Edam, Emmentaler, Gruyere, Harjagdata. And then the ones to avoid, which are processed, heavily spiced, and cheese in a canned product. Okay. So there are tons of foods in here. This is 30 years of work on the IC diet. And I completely updated our food list last year. But what makes it cool, so we've got a great food search area where you can type in the food. So if I start typing in cheese, it will immediately show all the cheese. So a really easy search. But what's even cooler is we have AI now in the app, and the AI is based entirely on our website and our diet book, right? It's based and guys, this is just the cover. The book is 84 pages long. I just reskinned everything last week. Okay, so it's, hi, I'm your IC 101 food assistant. Ask me anything about bladder-friendly foods, what to avoid, or dietary tips for interstitial cystitis. So I'm going to say, can I drink beer? Let's see what it says. So it's thinking. And it's only $4.99, guys. $4.99. The last one we did was free. And apps are very expensive to build, and I lost money on it, so I had to shut it down. This one, I'm just asking for $4.99 to try to pay for the development fees. Okay, so here's what it said. Hey there, I understand you're curious about whether beer is an option for you, and I'm here to help. Here's what we found about beer options. Beers and ales you can consider: light lagers, light hybrid beers, and light ales. Beers and ales to avoid: brown ales, stouts, hard ciders, German white or rye beer, Belgian or French ales. And the general recommendation: moderation is key. If you decide to try light beers, consider limiting them to a small amount to see how your body reacts. Listen to your body. Everyone's experience with IC is different, so pay attention to any symptoms that might arise after drinking. Alternatives that you can consider. And then it gives a lot of drinks there. And you know what we did yesterday? Oh, Anne. Anne's asking about multi-right. I'm sorry, about Bladder Smart. I'm not going to have it for probably 2 months. There was a our inventory was unfortunately sent to somebody else by the manufacturer, and we have to wait for the next production run. So what I have done, Anne, is I have brought back Multi-Right, which is the original low acid vitamin that I helped to create. And we just got it. It's not in the store yet. So it's the same thing. I mean, like literally, Multi-Right was the very first low acid vitamin for IC ever created. And it was my idea. I was working with the CEO of Far Laboratories. They used to make Cystacue. He asked me if there was anything new that I would make for an IC patient. I went, yeah, I'd make a low acid vitamin. He said, why? I said, because there's not a single bladder friendly low acid vitamin on the market. I mean, this was like 15 years ago, guys. And 6 weeks later, he called me back and he said, I've made you a low acid vitamin. It's Multi-Right. We sold Multi-Right for years, very, very successfully. But then the company had some issues. And they went bankrupt. And I needed it right away. I mean, it's a complex story. It's not just that. There were a few other things going on, people that were very difficult to work with. So I asked Natural Approach Nutrition to make us a low acid vitamin, which they did, which is called Bladder Smart. But unfortunately, we're not going to have it for a couple months. So a new company ended up buying all the products from Far Laboratories, including Multi-Right. And I introduced myself to them about 2 weeks ago and said, so do you know the origin story of Multi-Right? They went, no. I went, well, let me tell you, it was my idea. And I was actually promised a share of national sales by the first company. But of course, that fell by the wayside very, very quickly. So the new company is very competent, and I ordered 50 bottles. And so if you call me, and if you call me tomorrow, I can send out a Multi-Right to you to compensate for that. Okay. It just, it just is what it is. Things happen. We have to respect that things happen and accidents happen. Karen says, wishing you well. Thank you so much. You look great. Yeah, except for this. Like, where'd this come from? I don't get this. There's something about turning 60 that fundamentally changes your body. And then there's something about turning 65 that changes it even more. And so now it's like, okay, all the weird things, like I didn't have this before and it's bugging me. Life is funny. Hi, David. It's nice to see you, hon. How are you doing? You're welcome, Carlene. Julie says, thank you for another great Sunday Live support. You're welcome, Julie. Michelle says, estrogen cream helped my 92-year-old mom with her recurring UTIs. Thank you. Excellent. Glad to hear it. Karen says, wishing you well, and thank you so much. You look, thank you. I try. I'm getting impatient, but I try. Life is a journey. Here, hold on. All righty then. You're doing good. Excellent. Thank you, Karen. Sherry said, quick question. Have you heard of software therapy? Soft wave therapy. Unsure if you've already discussed it. Yes, there are a couple of different kind of low frequency therapies that are being used in the pelvis successfully. And I believe because it helps to reduce inflammation and promote healing. And if I remember correctly, Ken Peters, who one of the top IC doctors in the country, if not world, definitely one of our best researchers ever, he popped me an email not long ago saying that he was using, let me see if I can find his email. Let's see. I know he told me that he was using, oh, is that it? Yeah, no, he's using soft pulse. No, he's using soft wave. Okay, this was, it was a year ago. The soft wave has been a great addition to our pelvic pain treatment in women and men. We presented data at the American Urology Association conference, currently writing some manuscripts, developing a sham-controlled trial. We treat the perineum to pick up the pelvic floor muscles and the pudendal nerve and often the hips, which are pain generators. Additionally, specific areas can be treated, such as the penis for penile pain, clitoris for clitoral pain, and suprapubic, groin, and low back, wherever there are pain generators. Almost everyone feels better after treatment, and the pelvic floor is much relaxed. But since this likely works by activating genes that improve blood flow, nerve function, and attract stem cells, the long-term responders continue to improve 16 weeks and beyond after finishing 6 weekly treatment. Yeah. So there you go. One of the top IC doctors in the world is using soft wave in his clinic. And as he said here, almost everyone feels better after treatment and the pelvic floor is much relaxed. So that isn't, and he didn't solicit me. It was actually somebody who came to a support group meeting and said that they had gotten it done in his clinic and that it was helpful. And so I emailed him and said, hey, what's a soft pulse, soft wave thing? I'd like to learn more about it. I'd like to have it on my incisions. You know, I was at the gym. Oh gosh, let me see. Thursday, and I do not know what I did. I was lifting weights and I just killed my breast cancer incisions. And I was so cranky and annoyed on Friday. I was hurting big time. So I wonder if that would help with these incisions. I mean, it's just crazy. For those who don't know, I had a double mastectomy 2 years ago for breast cancer, and they got it all. It was stage 0. I didn't have to have chemo or radiation, thank God. But I am a rare neuropathy patient that when I woke up from the surgery, I felt like there was this very, very tight belt wrapped around my chest, and that has never gone away. And normally it goes away. It's better than it was, but if you see me doing this in meetings, it's just me subconsciously rubbing these darn incisions. Life is very unpredictable. Carlene said she had it on her ankle and it worked great. Sherry said, I've been wanting to order more vitamins too, so I'm glad you told us. Yeah, just call me and I'll do it for you for sure. Arlene says, how long does it take for the bladder to flare from a food that may not be bladder friendly, like watermelon or cashews? Well, if it's a very strong acidic flare, I would expect that you would feel it within an hour. But for more subtle flares, you're probably not going to feel it until you go to bed, because the normal distractions during the day often distract us from the early signs of that flare. And it isn't until you turn off the TV and, put your PJs on and get in bed that you realize, oh, my bladder is not happy. Now, let me describe how a bladder wall flare, the way I experienced bladder wall flares was at night, was interesting, because I wrote an article, Anatomy of an Utterly Ridiculous IC Flare, where I had 3 strong acids that day, and I was just oblivious to what it would do to me that night, which is brutal. So I went to bed at like 11, and you're kind of used to a little bit of irritation. It didn't feel that bad. So I went to bed at 11. I woke up at midnight, an hour later, and my bladder felt desperately full. And I was in big time pain. So I run to the bathroom, I pee, the pain goes away. I run back to bed, fall asleep again. I wake up a half an hour later. My bladder feels desperately full. I run to the bathroom and I get maybe a quarter of a cup at the most urine, very little urine, but I feel better because I peed. So I go back to bed. 15 minutes later, I'm up again. My bladder feels very, very full. I go to the bathroom, nothing comes out. I might push a little bit. I might get a drop or two. And then I am in the purgatory of a bladder wall flare. And at that point in time, your bladder is just screaming at you. One of the ways you know your bladder wall is incredibly irritated is by giving you a false sense of fullness. You feel full even when you're empty. And that's a real, I interpret that as kind of like your bladder screaming at you, help me, help me, help me. If you feel full, even when you're empty. And so that's for a severe bladder wall flare, you're stuck there all night long. And so I got to the point where I knew that trying to lay in bed with this bladder pain was simply not going to work. So I eventually got up, went into the family room, turned the TV on, got a really hot heating pad, and I turned on a really bad movie or an old movie that I love, like Harry Potter or Indiana Jones, something like that. And I just kind of would lay on the couch with my heating pad and the movie, and I would doze, and then I'd wake up and have to run to the bathroom and doze and wake up. And that's where pain medication really comes in handy, having something for the pain right then. And thankfully I did, because back then they gave us Vicodin. And so I would use a little tiny bit of Vicodin, and that would often help me get back to sleep. That very severe bladder wall flare for me would usually last a couple of days. But it got better progressively, because in essence, I had just wounded my bladder wall. I had like, what did I like for breakfast? I had eggs with hot sauce or salsa. For lunch, I had smoothie with like pineapple and pineapple juice in it. And then for dinner, I had an enchilada with hot spicy. I mean, I was an idiot. And that's why I wrote an article, Anatomy of an Utterly Ridiculous Icy Flare. It was totally my fault. And that just really taught me a lot about diet, and that I had control and I needed to follow the diet. You know, and it's interesting because I was having a conversation with my sister yesterday. Some people have trouble. Here, hold on a sec. That's another fire warning. Giving up food. For me, I was like, oh, hell yeah. I don't want any more nights bawling my eyes out in agony. If that means I have to give up soda, oh, hell yeah. I'll give it up in a heartbeat. I would rather give up soda than be in pain. I would rather give up coffee than be in pain. It's that easy. And so I'm very much if you tell me I shouldn't do it, I'm probably not going to do it. But more importantly, if I directly experience that causing me pain, I'm just simply not going to do that again. I don't need any more convincing. And there are other people who are like, I'm not going to let IC rob me of something I love. I don't care if I'm in pain. I'm going to drink that coffee. I'm going to have that soda. And they are in for a world of hurt. Especially if they have Hunner's lesions. And what I say to them is, you're thinking of this like you have an incurable disease, and you're not going to let this disease rob you of something you enjoy. I want you to think of this in a very, very different way. I want you to think of this as an injury, that you have an injured bladder wall, because acidic food is going to injure the bladder wall, especially if you've got Hunner's lesions or estrogen atrophy. So let's think of this like an injury right now for the moment. So if you had an injury on your hand, an open wound on your hand, would you pour coffee on it? And the answer, of course, is no. Why would I do that? Okay. Doesn't make sense, right? To bathe a wound in coffee. Now, what's going to happen to that wound if you pour coffee on it? Well, it's going to sting and hurt because coffee has a lot of acid in it. Okay, we get that. So what's going to happen to that wound if you pour coffee on it every day for a month? Is it going to heal, or is it going to get worse? And the answer, of course, is it's certainly going to get worse. You know, our job is to create an environment that will help this tissue heal. This is why we wash it in water and we put a Band-Aid on it, and we don't pour rubbing alcohol on it. Rubbing alcohol would sting. Well, if you have a wound in your bladder and you drink alcohol, it's going to sting. That's why it's so great. We've got all these de-alcoholized beers now. We were taste testing some yesterday. There's de-alcoholized beer, there's de-alcoholized wine that actually are a lot more bladder friendly. But in the end, your job is to help this tissue heal. And it's not going to heal if you keep bombarding it with acid every day. And worse, there is no treatment that can counteract the damage that's being done to that tissue by that coffee every day. You're literally throwing your money away on treatments if you're drinking coffee, because there's nothing out there that can reverse the damage that's being done by the coffee every day. So I have shared this story. I have a client who I spent a lot of time with when she first called, and I went through the diet extensively with her. And then I referred her to one of the top doctors in the world who lived literally 20 minutes away. I thought she was good. 5 years later, she called me hysterical. I don't know what to do, Jill. I'm in so much pain. It's terrible. It's terrible. Nobody's helping me. I'm like, okay. Tell me about your pain. So she had pain as her bladder filled with urine that was relieved by urination. And it's like, it sounds like you're having a bladder wall flare. Are you following the diet? And she goes, yes, of course I am. Now, and she really spoke like that. Her husband was on the line. He goes, no, she doesn't follow the diet. She drinks a pot of coffee a day in the morning and a 6-pack of Diet Coke in the afternoon. And you should have heard her wailing. Man, he outed her like she had never been outed before. And she just started wailing, that's right, take away everything I love. I can't live without my coffee and my Coke. I mean, she was wailing on the phone. So it's like, now wait a second. I told you about the diet. Didn't you believe me? And she said, no, didn't apply to me. I said, now I sent you to Rob Moldman, the guy who's actually done most of the diet research. Didn't you believe him? She goes, no, didn't apply to me. I said, now, every doctor you saw told you about the diet, right? She said, yeah. It's like, didn't you believe any of us? She said, no, it didn't apply to me. And I'm like, okay. Massive chemical damage to her bladder, like massive damage. So I said to her, I said, how much money have you paid for IC treatments in the last 5 years? I mean, she had done all the bladder instills, all the oral meds, and had surgery in interstim. So how much money have you invested in IC care in the last 5 years? It was like at least $50,000. And I said to her, I said, you realize that you sabotaged every single one of those treatments. None of them would have ever worked for you. And that caught her attention. She went, what? I said, listen, there's no treatment out there that's going to counteract you bathing your bladder in acid all day. They didn't have a bad chance in hell of helping you in any way, shape, or form. You threw your money away because you didn't listen to us. And she was like, what? And I just got really blunt with her. I said, you're addicted, aren't you? You're totally addicted. Hey, I'm going to shut down YouTube right now because it's done. The last person just left. Okay.